2, 1. Please start, ma'am. We are live.
Namaskar and a very good evening to one and all present here. I welcome you all for today's webinar on breast cancer update. And with immense pleasure, I would like to invite Dr. Hitesh Khatwani, who is co-founder and consultant medical oncologist, Oncovin Cancer Center, and consultant medical oncologist at Starlet Cancer Center, Ahmedabad, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Yeah, good evening, everyone. I welcome all the faculties, delegates, and my friends and colleagues for the Oncovin breast cancer update on behalf of Team Oncovin. In next 2 days, we are going to discuss about the recent updates regarding treatment paradigm and management of breast cancer, which have been discussed in recent important conferences like SABCS, ESCO, ESMO, and as well as year-end review. Today, for next 3 hours, we are going to discuss about the important molecular updates in breast cancer, followed by a session on hormone positive breast cancer. So thank you everyone for joining. And in first session, we are going to discuss about the molecular updates in breast cancer. I welcome you all on behalf of Team Oncovin. I think we'll start with the first session, which will be taken by Dr. Prashant Bagali sir. I would like to invite Dr. Prashant Bagali sir, who is practice head of oncology division of Stand Life Sciences Bangalore, and he is going to talk about molecular biomarkers in breast cancer and latest updates about it. This session is sponsored by Stand Life Sciences. Over to you, Dr. Prashant sir. Welcome, sir.
Good evening, everyone. Good at the outset, I would like to thank Dr. Hitesh Khatwani, the consultant and the co-founder of Oncovin Cancer Center, and also the organizing team, Dr. Modi, Dr. Kothari, and Dr. Bhatt. So it's my pleasure to be with you all. I'll just share the screen. Yeah. Doctor, is my screen visible?
Yes, sir.
Yes, sir. Please go ahead.
Yes, sir. It's visible.
Yes, sir. It's visible.
Yeah, thank you very much. So since I'm the first speaker, so I would like to have the 20 minutes only, so that the remaining, we have the interesting presentation later on the evening. So my presentation will have the some of the important points about the molecular markers. Before that, I will have 1 or 2 slides about the fundamentals of that, because of the group, which is already senior, but I just want to set some of those new updates which have been reported in NCCN guidelines and ACMG guidelines, and about the STRAND panel, how the panels are there and what are the clinical implications and the clinical utility of that. And of course, 1 or 2 slides on the test report and the VUS and some of the questions in what I usually encounter in the clinical practice. So as all of you know, the STRAND has a diversified interest in oncology. So not only the breast cancer, but also in the lung cancer, colorectal cancer, and the other different types of that. It's more than 21 years old company from Indian Institute of Sciences spill-off, and now with the part of the Reliance Group. Fundamentals of that is, why did I put always this, is because of my experience of being having a discussion in the HRD, which is both the kind of ovarian cancer and also has a lot of encounter with the breast cancer. So the cancer is both the genetic and the hereditary, because all hereditary diseases are genetic, but all genetic diseases are not hereditary. So that's very important. And in the somatic one are the germline, always everyone will have a lot of different opinions. So although cancers have the 70 to 80 sporadic, but still there is a heritable risk is very high, especially for the breast cancer or the woman cancers in general. But however, the age of occurrence, the progression of disease, inheritance patterns will play a very important role. The hereditary, whenever we say hereditary, it is basically on the germline tissues, and the sporadic is based on the somatic tissues. So that way, whatever is the detected in the hereditary or the germline ones will not be detected in the sporadic one, because sporadic ones are those which are acquired, or those genetic alterations which are acquired in the individual's lifespan. But these are what the germline ones are inherited from our parents. But clinical bioinformatics also play a very important role. So although I'm not insisting that you will have to know everything, but when the report comes to you, so you need to know that what are the reference database are used, or what is the read depth is used. Because whenever I get the questions, whenever they ask me, the doctor, well, how do we know that there are so many companies which have the same offering and the same set of genes, but when I go to the depth of the coverage or the genomic region coverage, there is a wide difference of it. And also in terms of the variant analysis tools, nowadays I see that there have been differences in the tools what the different labs are using, but Strand over the time of 20 to 22 years has developed its own NGS software and the interpretation software. So, and also we need to continue this story is an individual with a germline cancer mutation may develop the cancer in the somatic tissues also, because there is always a confusion that the germline, once it is detected, okay, it might not come in the somatic, or the somatic ones when they are doing, so they think that no germline, there will not be any risk in the family. So this is very important, because later on I'm going to share some of the NCCN guidelines. And also germline cancer tests analyze the cancer causing mutation only in the inherited from the parents, like I already told. And there are also risk of multifactorial. That's why always earlier 1 or 2 genes were there, but now we do the panel of genes. If you go through the NCCN guidelines over the time of the new guidelines which is there, earlier they were saying multi-gene panel can be explored, but now they are trying to say that multi-gene panel need to be as a kind of category 1. It's a preferred only. So the polygenic inheritance has been established, but please remember, when I say polygenic inheritance, there are many genes, but each individual gene will have its own inheritance pattern, will be either homozygous or heterozygous. So this is where the cumulative effect of that is what we always see in the patient. And pleiotropic effect is another interesting one, because although you might have been treating the patients with Lynch syndrome or the syndromes where there is relapse or recurrence happens with a different site of a cancer. So those are mainly because the pleiotropic effect, the multiple effect of the genes of the 2 different cancers. So quickly going to this guideline, which I picked it is because hereditary cancer criteria always shares with the breast cancer, ovarian cancer, pancreatic cancer, prostate cancer, and colorectal cancer. Although now we have a very neatly defined prognostic markers or the treatment guidelines, but there has always been a confusion with regard to the hereditary cancer panels. So if you are having any of those questions, so it's always better to start with the broader panels and then come back to the one which is very neatly having a clinical implication in the patient. So what is the I just summarized in few of these points. So some individuals may carry pathogenic or likely pathogenic germline variants in one cancer susceptibility gene. But in the when we do the multi-gene panel of the individuals, it will carry not only the single pathogenic and but it also cover on the broader spectrum of the other genes which are having a strong evidence of the absolute risk on the patient. And also the germline confirmatory testing should be done always on the pathogenic variant, which is found in the tumor genomic testing that has a clinical implications. And whenever there is a tumor tissue, testing is designed to address the treatment actionability. So then germline test, because germline test should not be selected in those cases when we know that we have the disease symptom, there is a significant tumor in the patient. So this is very important. Simple reason, later on I will explain that the lab which is doing it might not report, like filtering the raw sequence may differ with the tumor and the germline testing. So that's where importance comes to the bioinformatics one. So this I just could able to pick up because of the the pleiotropic effect of the gene, because whenever I try to explain in the different CME, I'll always find this it's very interesting one and all, or especially when there are some labs which are directly offering whole exome sequencing on the affected individual. So it's not to be like here we have the different genes on the different clinical conditions. So this is being reported, but we need to be in the cancer, need to be very careful to choose those which are very important for us in the clinical actionable targets only. So I just took the invasive breast cancer to start with from the first line of the treatment. So in the treatment setting and the PD-L1. So whenever there is a combined positive score more than 10, regardless of the germline BRCA1 and 2 mutation status, then we have the treatment regimen. So I will not talk more about the treatment regimen because this is the first presentation, and later on we have the interesting one. So probably we have the excellent discussions at that point of time. But why did I highlight is the biomarkers surely have a greater implication in these cases. In the invasive breast cancer, whenever there is a PD-L1 score is the combined positive score is more than 10 or less than 10, and when the genomic BRCA mutations is negative, then what is the treatment need to be taken in those conditions. So, and some in the third line one, because now in India, always that you get the patients either with the advanced stage, the stage 4 of them. So there the third line treatment will always be with the microsatellite instability, whether MSI score is high, or sometimes now the indications are also there for NTRK, RET, and the tumor mutation burden. So these are very important in the biomarkers we need to consider for the invasive breast cancer. So this is another one where the biomarkers play a very important role in this case. So here I will just not include the BRCA because I covered in the previous one. So here we have the HER2/neu and the PIK3C and the PTEN. So in the ER positive cases, whenever there is a HER2 negative breast cancer, the mutations in the PIK3C are there. So it will always have an enhanced response. So if you see in the test reports, so whenever there is a HR or HER2/neu is detected, or it has any kind of those indications, pathogenic or likely pathogenic, they should always see that there is whether the response is mentioned or not in the report. So in those cases, it becomes very important. Some of the immunological markers also are very important to just to know or to reconfirm that for the quicker test results. So this is the one slide which is very important because in the HBOC, because breast and ovarian cancers always have the commonality with regard to the genes, what they are doing, either it is a BRCA1 and BRCA2 gene. So in those cases, there is always a very strong relationship between the germline mutations and the somatic mutations. But in the germline mutations here, we have around 5% of the risk for the breast cancer. But another important thing is whether those genes which are all positive in the patient, whether pathogenic or likely pathogenic, for a high risk of the gene, moderate risk of the gene, or a low risk of the gene. Why it is very important is, I have the next slide where there is an absolute risk also has been now evaluated over the many studies, because earlier in the NCCN guidelines, they will always used to not mention about the other genes, these smaller genes like ATM, CHEK2, and the PALB and all. But over the time, we have evolved now. It has been discussed even in the ASCO and the ESMO guidelines, very clear cut in terms of the absolute risk for these important. I just could able to select some of these genes and their absolute risk, and what is the occurrence in terms of what is the resource associated with this. So in those cases, if you see here, BRCA1 and BRCA2 is more than 60%. It's all absolute. The second column is in the percentages, and this is a strong one. So male breast cancer is also there, but it is only 1.2% of the risk by age 70. And here also the BRCA2 is rather more very strong risk to the male breast cancer. But in the female breast cancer, both of them, these more than 60%. And we have the other like PALB2 or the P10, and also there are they have the approximately CDH1 or 60% risk, absolute risk. But some of the important one which earlier we were missing is the ATM gene, BRD gene, NF1, RAD51C, and the RAD51D, which are all about 20 to 40% risk, is a strong risk and all. But you might always see that in India, we sometimes this data will not corroborate, or rather it is sometimes underestimated. That means we have not have a strong data to support this, but certainly we have seeing this kind of the data in the Indian population also. So probably in the subsequent presentations, I will cover some of those our Indian study also. So based on that, the Strand has designed some of these molecular markers or the panels, and panels which are very important, although the first two ones are immunologic IHC based, but the HBOC panel has not been the 4 gene only. Earlier, like you saw in the table that these are having 60%, like 40 to 60% of absolute risk, but the 19 gene which covers all of these genes, the two reasons for this, sometimes the bigger panels, why the bigger panels will go for the smaller panel is always some of the doctors will always ask me and all. But my only thing is, of course, if you are absolutely sure there is a hereditary risk of it, okay, go for only the specific of 4 genes panel and all. But when you are not sure about that, then having a broader panel will have achieved 2 important benefits to that. One is it will benefit if these of the 4 important genes are negative, are not detected, and there is any pathogenic or likely pathogenic variants or a VUS is identified in any of the other other genes, then also it will have an actionable kind of for us to have the better treatment treatment decisions and all. So in those cases, going for the broader panels, or sometimes hereditary ones like 35 panels. So I will not go in depth about the HRR and the HRD one. So this is the VUS one. So VUS is also very important because and the Strand has that good reputation of classifying the Indian subcontinent germ lines because of the database what it has accumulated, more than 10 to 20,000 in this region. So please remember that nowadays the new guideline says that counseling is very important, in fact mandatory for the VUS whenever it is identified, and no clinical procedures or recommendation should be done unless otherwise the tumor board of exactly takes a decision that okay, such a thing will help the patient. So, and the VUS are very common, and because of the multi-genes panels whatever we are using. So this is another interesting slide which I wanted to share with everybody is because whenever the discussions are happening for especially in the HRD space, though there always been questions like whether the genomic BRCA which is identified in the other panels, is it the same, or is the somatic BRCA identified is in the same in the other panel. So here I've just compared the whole exome sequencing or clinical exome sequencing HBOC panel, somatic BRCA as an individual test. We also have it, and some of the other labs also have it, and the HRR panel also has the somatic BRCA along with those 14 genes what you saw in my table earlier, and of course the HRD one which has the somatic BRCA in that. So here the third row is what I am trying to say. So third row is very clearly mentioned that see, the first two are the germline mutations only. So whatever the exonic regions, the coding sequences, what is covered for the BRCA1 and BRCA2 are only about the exonic regions only. And in the 3 of the somatic one, they only cover the somatic mutations in those exonic regions, and they will not cover the germline mutations and all. So, and also there will be an intron exonic bridge also covered, so that way these panels are little broader. in applications, and the kind of amplicons used, the fourth row is a kind of amplicons used in these panels will be entirely different from what we are covering in the exonic review. So that way choice of the library becomes very important, and depending on that only whether you will have whether you are planning for a deletion is present in the person, because whenever the somatic alterations are happening, it can be any one of them, like the small deletion or insertion or a copy number variation and all. But here in the germline one, it is very straightforward that either a point mutations or the indels or any of those things are there. So the genetic counseling, as I rightly said, is very much mandatory. So we have a board certified genetic counselors who take care of both the pre-test counseling and also post-test counseling. Especially in the breast cancer, it has been, in my experience of working in India, has been very challenging for us with regard to make sure, and that's why we include the different languages also, like starting from Hindi, Marathi, Kannada, Gujarati, and the other languages, Tamil, Telugu, and Malayalam, and also in the Assamese and West Bengali. So these are very important because only the women who are the family members will open up with when they talk in the same language. So it becomes very important for us to understand that. So these two slides I'll just cover before ordering the test. What I request all the dignitaries here, and some of them you have been practicing many years, so you need to know that what's the specific clinical condition of the affected, whether the panel what you are choosing really fits to that, does it cover all the variants which are all required for that, and of course benign is not mandatory to report, but likely pathogenic VUS. Nowadays we also report the VUSD, which is like a variant of uncertain significance of the damaging effect, where the literature says that some of them are also associated with the damaging effect. And the zygosity one, like whether it is heterozygous or homozygous, or the inheritance, whether it is autosomal dominant or autosomal recessive. So these are very important one, need to be covered in the report. And sometimes whenever you are having the somatic tests, you need to also know that whether the biomarkers are also related to the targeted therapy or immunotherapy, and also whether the second in the germline findings you will have the secondary findings also, whether it is present, because whenever you recommend the first degree relatives for the germline panel also. So, and mutation specific, this is one important thing I always say, that whenever clinically actionable is there, of course the patient is important for us, we should start the treatment, but please remember that with the mutation specific test of the first degree relatives or the secondary degree relatives, or at least minimum first degree relatives, by using any of the germline tests become very important. So this cannot be ignored in any of those conditions. And yeah, this is just the content of the report for our discussions and all. So if any questions are there, I'm willing to answer. Yeah, these are some of them which I always regularly see in our conversations with the germline and all. Whether the second method validation is done, doctor, how many times, or what method you use. So sometimes we do the MLPA and sometimes we do the Sanger sequencing, because MLPA, then whenever there is sometimes confusion that, okay, the somatic BRCA is detected in the NGS, but is not detected in NGS, but later on MLPA shows the positive. So this is very important, because what kind of the deletions are covered, what size, like base pairs. If I say that a base pair of 10 kb is covered in the NGS, then, or a length of the probe is covered, then MLPA covers the larger deletions and the insertions and all. So this becomes very important to have the understanding and all. Yeah, thank you very much, Doctor.
Thank you, Dr. Prashant Bagali sir, for the wonderful insights on molecular biomarkers of breast cancer. I think we have one question from Dr. Palak Bhatt. And should we order MLPA testing? And which of your panel covers that?
Yes.
That question is from my side. Second.
Yeah, MLPA is a second method validation. It's independent of the NGS. So
yes.
There are some criteria when we follow. For example, if there is a case of high-grade serous ovarian cancer and then recurrence with the breast cancer, so then the HRD is conducted. HRD comes negative, then MLPA can be done. So just to reconfirm the BRCA status. And the second one is whenever there is a strong family history of BRCA, germline strong family history, then you can go for the MLPA directly in those cases, because MLPA will certainly identify both the somatic BRCA. MLPA identifies those mutations which are associated with that. So those are the two scenarios which are very important from the MLPA perspective. But please remember that MLPA, because some people without knowing the germline BRCA status directly go for the MLPA, and if it is not detected, they try to confirm or convince themselves that BRCA is not there. That's wrong, because whatever the point mutations NGS can identify, MLPA will not be able to identify. So that way, it's always a sequence, a reflex testing or a second method validation as an MLPA is preferred rather than starting as a first line of diagnostic testing.
Thank you, Dr. Prashant Bagali sir, for your wonderful insights. We would move to the next session. We don't have any questions. Second session. For second session, I would like to welcome Dr. Manjari Bhakre ma'am from Bangalore. She is CEO and founder of Oncostem Diagnostics Private Limited. She is going to talk about prognostication in hormone positive EBC, selecting the right tool for our patients. This session is sponsored by Zydus. Welcome, Dr. Manjari Bhakre ma'am.
Thank you so much. I hope you can hear me.
Yes, ma'am.
Yeah, and let me start by presenting, sharing my screen. All right. Okay. So thank you, organizers, for this opportunity. It is always a pleasure talking about the tool that we have developed, Oncostem has developed on prognostication in hormone positive early breast cancers and HER2 negative. So the clinical dilemma that clinicians face in treating hormone positive HER2 negative EBCs is because they have the best prognosis amongst the breast cancer, amongst the gamut of breast cancer patients. Which of the early stage hormone positive HER2 negative EBCs should we treat with chemotherapy? That's always the question that is on clinicians' mind, especially when the tumors are small and patients are perimenopausal, etc. So prognostic tests have been developed precisely for that reason, which are really helpful in identifying those patients whom to treat with chemotherapy or avoid chemotherapy. Prognostic tests are of main 4 or 5 prognostic tests are available today. Oncotype, MammaPrint really lead the field, developed in the US and in Agendia in the Netherlands. They are in most of the guidelines as well. EndoPredict, Prosigna are also used in India to some extent. All of these tests essentially segregate the EBCs, hormone positive, HER2 negative EBCs into 2 buckets, those who have a low risk of breast cancer recurrence and those who have a high risk of breast cancer recurrence. And all of them predict distant recurrences. And based on that, treatment can be planned accordingly. Of late, however, there has been a lot of data suggesting that all of these tests don't work equally across all ethnicities. Especially Oncotype has been showcased to work not so well, not as well as it works on Caucasian as on African Americans or Hispanics. MammaPrint has been shown to work very diversely in Japan and in Korea. So that is really the issue that people are facing, and they're looking at ways to come out of that, maybe to rescale the scores or maybe to adjust them a little bit for Asian patients. And our ICMR guidelines also don't include these Western prognostic tests due to inadequate validation on Indian patients. If you look at TaylorX and RxPanda, the number of patients from Asia itself is low, and out of that, from India is even lesser. So multi-gene tests such as MammaPrint, Oncotype are specifically not included in ICMR guidelines, as they have very little clinical validity on Indian patients. So the reason why ICMR did that is also because the way the disease presents in Asia, in up to Middle East compared to the West. in India, in Asia in general, in Middle East as well, whenever we give talks, we hear that our median age is premenopausal at around 46 to 48. And it's often the symptomatic detection happens. So it leads to identifying patients with higher tumor burden, and typically we get one lymph node positive patients. Whereas in the West, the disease presents in postmenopausal phase. The median age is about 58 to 60. The patients are typically screen detected, mammography detected, so small tumors and primarily lymph node negative. So obviously the tumor burden is smaller. So as we see, the problems are our breast cancer onset at a younger age in our patients, and with a node positive grade 3 high Ki67 disease. So we felt that we need a test, a prognostic test that is suitable for our patient in terms of it represents the tumor biology of our patients. And therefore, in 2011, I incorporated OncoStem Diagnostics to develop a prognostic test, which would be developed on our patients' tumor samples representing our patients' tumor biology, and which would be validated all over the globe. So the unmet need is really CanAssist Breast, which is developed on Indian patients. What is CanAssist Breast? It's a prognostic test that is performed on formalin-fixed paraffin embedded tissue that is removed during surgery. It is the only prognostic test which is performed using immunohistochemistry as a technique. We do immunohistochemistry for 5 biomarkers. I will get to the names of these biomarkers. These 5 biomarkers are critically involved in spread of the disease starting from the duct in the breast to elsewhere in the body. These IHCs are graded by trained oncopathologists in our lab, and that data gets into our machine learning based algorithm, which is developed by our statistician based in the US. Along with the IHC data, we also include that particular patient's tumor size, tumor grade, and the lymph node status. All of this information, once put into the machine learning based algorithm, we get a numerical between 0 and 100. We call that CanAssist Breast risk score. Depending on the value of the risk score, patients are segregated into 2 buckets. If the risk score is 15.5 or lower, the patient is considered to have a low risk of breast cancer recurrence, and about 70% patients in EBCs fall into this category. If the risk score is 15.6 up to 100, patients are considered to have a high risk of breast cancer recurrence, and about 30% patients fall in this bucket. And based on that, treatment can be planned as per the clinician. CanAssist Breast today has been validated on close to 4,000 patients in India, in the US, and in multiple countries in Europe. I will show you the data. It has high accuracy of 95%, which is comparable to Western tests such as Oncotype DX. The patent for the 5 biomarkers that we work on is granted in multiple countries, and we have several peer-reviewed scientific publications. So this is one question I often get, which are these 5 biomarkers that CanAssist Breast uses? Does it use ERPR, HER2, and Ki67? The simple answer is no. We don't use any of these 4 markers, which are routinely used today in every lab. We go beyond proliferation and hormonal indices. The 5 biomarkers we look at are CD44, 2 cadherins, and ABC's transporter proteins, because they definitely have a role to play in cancer progression. As you can see in this slide on the cartoon on the left, cancer begins in the duct, and those tumor cells need to acquire certain properties, and which would lead them to come out of the tumor, invade, lose the cell adhesion, come out, invade the vessels, and then extravasate into another organ, and then become epithelial again, and then become chemotherapy resistant in the process, and make another tumor. And so these 5 biomarkers are critically involved in these steps. They are constantly talking to each other. There are lots of molecular interactions happening during this process as well. And we looked at a variety of biomarkers and zoomed in on these 5 because they had critical role in predicting risk of breast cancer recurrence. The development of this novel proteomic classifier we call CanAssist Breast is published in 2018, and followed by analytical validation as well as validation of CanAssist Breast not only on the FFPE tumor blocks, but also on tissue microarrays made out of these tumor blocks into various publications. Coming to global validation of CanAssist Breast, CanAssist Breast today has been validated in 12 different studies in India. in 3 different studies in the US, covering 3 different cities, and in Spain, Germany, Italy, the Netherlands, and Austria. And as we speak, one more study in Turkey is underway. Now, coming to clinical validation, that is really the proof of the pudding of CAN-Assist Breast. All of this data has been published in multiple publications. I will be happy to send you those publications. So CAN-Assist Breast generates actionable risk groups. So what do we mean by that? When you have patients who have early stage hormone positive, HER2 negative breast cancer patients, and if you run CAN-Assist Breast on those tumor tissues, it will segregate patients into either low risk for breast cancer recurrence or high risk for breast cancer recurrence, as can be seen in these 2 Kaplan-Meier survival graphs. What is the difference in these 2 KM curves? One, the KM curve on the left is all the patients were treated with chemotherapy plus endocrine therapy, and CAN-Assist Breast is segregated them as 70-30 into low risk versus high risk. And as you can see, the low risk patients do have improved distant metastasis-free survival at 94% compared to the high risk patients at 82%. One can argue that some of these, since all of these patients got chemotherapy, they may have, the low risk patients may have advantage derived from the chemotherapy in improving the DMFS. So we did a subgroup analysis in which none of the patients were treated with chemotherapy. All of these patients were treated with endocrine therapy alone. And as you can see, once again, CAN-Assist Breast segregates into low risk versus high risk, 80-20 here. And the low risk patients have an improved DMFS of 95% compared to the high risk at 84%. This goes to show that CAN-Assist Breast based risk stratification has a high NPV of beyond 94%, and it is not, the segregation is not affected by use of chemotherapy. What about age of the patient? Often, as I mentioned, our patients are younger at disease onset. So we looked at patients who were premenopausal below 48, as well as postmenopausal beyond 48 years of age. And as you can see, CAN-Assist Breast is able to segregate both sets of patients in a statistically significant manner in low versus high risk for distant recurrence. And the low risk patients do have improved survival compared to the high risk patients in the same category. And even the percentage risk is almost similar, about 67-33, 70-30, indicating the CAN-Assist Breast risk stratification is independent of age, and it truly represents the tumor biology. What about the lymph node status? So once again, we often get T2N1 patients, 2.5 centimeter with 1 lymph node positive disease. So we looked at patients who were entirely lymph node negative versus lymph node positive up to 3 lymph nodes N1 disease. And as you can see, in both scenarios, CAN-Assist Breast-based risk stratification was statistically significant, and the low risk patients do have 95-92% DMFS compared to the high risk patients, which is much lower, indicating that CAN-Assist Breast is able to segregate patients even into 2 categories who are even lymph node positive up to 3 lymph nodes. What about, this is another question we often get, how will CAN-Assist Breast help me to treat my clinically low risk patients? So clinically low risk here means T1 lymph node negative, maybe the patient has low Ki67 and perhaps high, perhaps elderly age, postmenopausal. So more often than not, these patients are spared from chemotherapy, but CAN-Assist Breast is able to find, what I'm trying to showcase here is, although TNM and ERPR, HER2, etc. are important, they are not the only ones. We don't mean to belittle importance of these parameters, but what we are trying to convey by this slide is, look at this clinically low risk patients. Even in T1 lymph node negative, there is a finite population of 7% patients who were stratified as high risk by CAN-Assist Breast, and they do have a lower DMFS at 85% compared to the low risk by CAN-Assist Breast, who enjoyed a better DMFS of 97%. And the same scenario in T1 or T2 up to 5 centimeter tumors, lymph node negative was 96 versus 85. And there was a 9% patient population who was stratified as a high risk for breast cancer recurrence as per CAN-Assist Breast, and they indeed have a lower DMFS at 85%. This goes to show that because CAN-Assist Breast looks at these additional pi biomarkers beyond what is seen today, if all things equal, TNM, ERPR, HER2, CAN-Assist Breast, because it looks at the 5 biomarkers, additional tumor biology, which is indicative of aggressiveness, it's able to find these high-risk patients from even clinically low-risk disease. And this really reminds me of this really wonderful article written by Professor Cliff Hardis, who is ASCO CEO, Biology Before Anatomy in Early Breast Cancer. So we truly believe that CAN-assist breast helps to understand the underlying tumor biology in an early stage tumor, and hence is able to find the high risk patients in anatomically or clinically low risk patients. Now, I have said this that more often than not in this presentation that the high risk patients do get benefit of chemotherapy, but have we shown that conclusively? So here is the Kaplan-Meier graphs, but here we looked at the data differently. Here we looked at all of the patients stratified by CAN-assist breast as low risk versus high risk. And then we looked at patients who did not get chemotherapy, the red line, versus patients who got chemotherapy in addition to endocrine therapy. As you can see in the Kaplan-Meier graph on the left, in this case, whether patient got chemotherapy or not, the blue or the red line, they are overlapping when patients are stratified as low risk by CAN-assist breast, and this DMFS is at 96%, indicating when CAN-assist breast calls the patient low risk, there is no added benefit of adding chemotherapy. On the contrary, when CAN-assist breast segregates patients as high risk for breast cancer recurrence, and if chemotherapy is omitted, look at the red line given the patients are treated with endocrine therapy alone, they tend to have a recurrence and the DMFS is down to 81%. But if you add chemotherapy to the regime to the treatment regimes in patients who are called as high risk, there is improvement from 81 to 90% in the DRFI, distant relapse-free interval, indicating chemotherapy is benefiting only in patients when the patient is stratified as high risk by CAN-assist breast. What about how well does CAN-assist breast work on non-Indian patients? So as I mentioned, MammaPrint as well as Oncotype did have differences in the way it worked across white Caucasians versus Hispanics or African Americans and versus Asians. So we looked at how does CAN-assist breast work in Indian subcohort versus all the Caucasians patients that we have tested so far, that is Americans and a few countries in the Europe. Whether these patients were treated with chemoendocrine therapy or endocrine therapy alone, Indian cohort versus Caucasian cohort, CAN-assist breast is able to segregate all of these patients in a statistically significant manner, and even the proportions are pretty much the same. In chemoendocrine therapy, it's about 70:30, and in endocrine therapy, it's about 80:20. So this goes to show that the underlying tumor biology that CAN-assist breast looks at is very similar across the different ethnicities and races that we have tested so far. This data was published in the breast last year. Now, I'm sure you all must be thinking all of this data has so far I have showcased is up to 60 months, that is 5 years from diagnosis. But hormone positive patients do tend to recur up to 10 years from diagnosis. That can also change because until a few years ago, hormone therapy was given for 5 years. But now hormone therapy importance has been recognized and it has been extended in high-risk patients as well. But we wanted to understand if CAN-assist breast will be useful in predicting 10-year recurrences. Such studies are not possible to do based on retrospective analysis of tumor tissues archived at the hospitals and with follow-ups. And hence we have been writing to multiple trial coordinators across the globe to help us validate CAN-assist breast on the trial samples. One such trial is TEAM trial. TEAM trial stands for Tamoxifen Exemestane Adjuvant Multinational. It was a large multi-country prospective randomized trial conducted in Europe over 9 countries over 12 years. And they randomized patients for sequential tamoxifen plus exemestane for 5 years altogether versus 5 years of exemestane alone. Out of these 9 countries, there was one center in the Netherlands called Leiden University Medical Center who had 480 patients' tumor tissues archived with them. So when we wrote to them about this novel test, they were excited and they were willing to share their tumor tissues where they have followed patients up to 12 years. And we conducted CAN-assist breast on those tumor tissues and we validated it in their cohort. Interestingly, unlike the TAILORx cohort or even RX Founder for that matter, this cohort was slightly challenging. It was all of postmenopausal and 67% was lymph node positive. more than T2 tumors were 55%, G3 tumors were 28%, G3, sorry. And despite all these clinically high-risk features, patients who did not receive chemotherapy were 78%. So we were really curious, how would CAN-Assist Breast work to predict risk of 10-year distant recurrence in this cohort? Will it do it or not? So when we looked at the Kaplan-Meier analysis of this cohort, as you can see, CAN-Assist Breast segregated not only in the total cohort, but in each of the arm, exemestane versus sequential arm as well. The low-risk patients from high-risk patients in a statistically significant manner across each of these arms as well, indicating CAN-Assist Breast can predict recurrences up to 10 years from diagnosis. And in all of them, low-risk the patients at 10 years have a better survival compared to the high-risk patients. Now, we have done multiple benchmarking studies of CAN-Assist Breast with the online tools, NHS Predict, ISC4, Luminal A, Luminal B, Ki-67, and also multi-gene tests, Oncotype DX and MammaPrint. Today, in view of time, I will only showcase you CAN-Assist Breast comparison with Oncotype DX. This is a head-to-head comparison where Oncotype DX was done first and treatment was planned based on that. And then we got those tumor tissues and we did CAN-Assist Breast predict. In this slide, CAN-Assist Breast called about 83% of this cohort as low risk, as against 90% by Oncotype DX. And interestingly, if you look at the negative predictive value, that is accuracy of CAN-Assist Breast with Oncotype DX, whether we look at it in total cohort, in endocrine therapy alone cohort, or in lymph node negative cohort, CAN-Assist Breast has an accuracy of about 94%, which is very comparable to Oncotype DX accuracy at about 91 to 92%. And one other question that was really on our minds is, what is the concordance in the low-risk patients? Remember, low-risk patients are the ones who will be spared of chemotherapy. And hence, we were curious if both the tests would call the same patient low-risk. And that concordance is 83% by both the tests in the low-risk category. And of course, as you can imagine, the cost of CAN-Assist Breast is a fraction of the cost of Oncotype DX, indicating CAN-Assist Breast can do the same job that Oncotype DX is doing at a fraction of a cost. We have done the same analysis on MammaPrint also, and we have 85% concordance in with MammaPrint low risk and CAN-Assist Breast low risk. Now, all of this data is great, but how does it really help how is CAN-Assist Breast helping our patients today? So we have been in the market since 2016, mid-2016. CAN-Assist Breast has been prescribed by clinicians, more than 350 clinicians across 40 different cities, not only in India, but also in Turkey, UAE, Sri Lanka, Bangladesh, and also recently in Vietnam. And about more than 3,000 patients whose treatment has been planned, and about 75% of them were low risk and have avoided chemotherapy, leading to not only savings, but improved quality of life of the patients and even better treatment for the high-risk patients in terms of probably adding CDK4/6 inhibitors, probably adding better follow-ups for them, and many other things that one can add for high-risk patients. CAN-Assist Breast is also reimbursed by private and public insurances in India on a case-by-case basis, although we don't have an absolute mandate in the central government scheme so far. But we are working on that. I would like to end this presentation by showcasing actually three patients who have used CAN-Assist Breast to plan treatment, and they have finished 5 years since the CAN-Assist Breast test was done on them. They were all 2016 patients. The 31-year-old patient Mrinal, who was recently married, wanted to have a baby, was diagnosed with grade 2 T2 high Ki-67 disease. And similarly, Jesse, 36-year-old, who did not want chemotherapy, was once again diagnosed with T2 16% Ki-67 disease. And patient Kritika, who was 56-year-old and was hesitant about chemotherapy, was again diagnosed with grade 3 T2 tumors with 30% Ki-67. All of these patients were low risk as per CAN-Assist Breast, and they all have been spared of chemotherapy since 2016. And this particular patient, Mrinal, was in fact, because she avoided chemotherapy, she was post-surgery radiation, she had a baby first, and then she was put on endocrine therapy. So this is how CAN-Assist Breast can help you plan your baby, and this is really, I mean, the patient was extremely happy about this. All of these patients have had no recurrences, are doing fine, and this 31-year-old even had a baby who is now almost 5 years of age. So part of this data on prospective use of CAN-Assist Breast in treatment decision has been published, and we are working on the next manuscript. So why CAN-Assist Breast in India? Because it has multi-country validation. It is validated on younger patients as well as older patients. It is an affordable innovation. It uses cutting-edge machine learning-based algorithm and potential for drug development. We run CAN-Assist Breast as a service from our central lab based in Bangalore, which is CAP accredited, Enable accredited, and the test and the lab, CAN-Assist Breast and lab are ISO 13485 certified, and our turnaround time is the fastest within 8 working days. So this is the summary of what I just described, and these are all our publications, and we'll be happy to take questions.
Thank you, Dr. Manjari ma'am, for the wonderful insights on CAN-Assist Breast, which I often describe as Indian women's oncotype DX, as I recommended to most of my patients in Indian setting. And one question from my side, that many times we have a patient like 70 to 73-year-old female with T3N0 borderline, like 5.5 centimeter lesions, and if it is grade 1 hormone positive, then do we have some data of using CAN-Assist in such set of patients, or it is still T2N1 only? That was a question from my side.
So T3N1, was it?
T3N0.
T3N0. We have data on T3N0s also. I can pull it out, and we have gone in terms of age. We have age up to 84 also covered in CAN-Assist.
Wonderful. Thank you, ma'am, for the wonderful insights on this. I think we'll move to the next session. This was a wonderful discussion regarding molecular biomarkers and about CAN-Assist Breast in the molecular session. Now we move to the next session, in which we will be predominantly focusing on hormone positive breast cancer. For next session, I would like to invite Dr. Palak Bhatt, who is consultant medical oncologist at Oncovin Cancer Center, Ahmedabad. He will be presenting about 2 abstracts. First abstract is Emerald, which is LSStant versus investigator choice standard of care in hormone positive HER2 negative breast cancer. And second would be about Capitilo, that is capivasertib plus fulvestrant versus placebo plus fulvestrant in AI resistant hormone positive HER2 negative advanced breast cancer. Over to you, Dr. Palak.
Thank you very much. Very good evening, everyone. So we all know that we have multiple options of hormonal treatment, even in adjuvant setting, and now we are using upfront hormonal treatment in MBC as well, when patient is not in visceral crisis. So these 2 abstracts I'm going to present here. First one is Emerald study, which is Elacestrant versus investigator's choice in patients of ER/PR positive and HER2 negative metastatic breast cancer setting. Inclusion criteria were all the male patients and postmenopausal women with ER positive HER2 negative metastatic breast cancer, either relapse or progression of the progressive disease after first 1 or 2 lines of hormonal treatment, who had taken less than 1 line of chemotherapy in advanced setting, and ECOG performance status in this study was 0 or 1. Total 478 patients were enrolled, and they divided equally in both the arms. In Elacestrant group 239 and investigator's choice it is 239, and the choice is up to the guideline and according to the patients, according to the oncophysician's choice, like fulvestrant, anastrozole, letrozole, or exemestane, and that has been given for until the progression or unacceptable toxicity or withdrawal of the patients. Co-primary endpoints were PFS in all the patients, PFS in all the patients with ESR mutation, ESR1 mutation positive, and key secondary endpoint is overall survival. Next. Baseline characteristics like median age, ECOG status, gender, visceral metastases are largely similar in both the arms. Prior hormonal treatment in first line or second line settings, prior any chemotherapy are largely similar in both the arms, in both the condition, all the patients, as well as in patients with estrogen receptor 1 mutation positivity. Next. So we can see that when patient has taken CDK4/6 inhibitor in upfront MBC settings for more than equal to 6 months, 12 months, and 8 months, when they were enrolled in this study, PFS for 6-month PFS in elacestrant group is 34% versus 19% in investigator choice. 12-month PFS in is 21% versus 6%, and 18-month PFS is 16% versus 3%. We can clearly see that when patient has taken CDK4/6 inhibitors for longer period of time, they have very good response to the elacestrant drug. For example, in CDK4/6 patient who has taken CDK4/6 for more than 18 months, 18-month PFS in elacestrant group is 21% versus only 4% in patients with investigator choice drug. Next. Same who have taken less than 6 months of the treatment, 6 to 12 or 12 to 18 months of CDK4/6 inhibitors. Here also clearly we can see that elacestrant group has very good response. Yes, definitely it is less than those who have taken for longer duration of CDK4/6 inhibitors, but still they have better response than the investigator's choice drug. Like a patient who has taken only 6 months of the treatment, 6 months PFS is 34% versus 19%. 12-month PFS is 23% versus 11%, and 18-month PFS is 11% versus 11.7%, which is largely similar in both the arms. Next. So now this is important that ESR1 mutation status. We generally do not do ESR1 mutation analysis in every patient, but in this study, circulating DNA was tested for ESR1 mutation status, and around 103 patients were enrolled in elacestrant group versus in investigator choice 102 patients were enrolled. And we can see that whenever when patient has ESR1 mutation, response to the elacestrant is very good as compared to the investigator's choice drug. 6-month PFS is 42% versus 19% in investigator's arm. 12-month PFS is 26% versus 6% in investigation arm. Even 18-month PFS is 20%. Even when patient has taken CDK4/6 for more than 18 months, 18 months PFS is 30%, whereas only 0% in investigator's arm. Next. Same in PFS less than 6 months, when patient has taken CDK4/6 for less than 6 months, 6 to 12 and 12 to 18 months in ESR1 mutation arm, 6 months PFS is not reached, but in investigator's arm it is 14%. But when patient has taken CDK4/6 for 12 to 18 months, 6 months PFS is 49% in elacestrant group versus 13% in investigator's choice. 36% in 12 months PFS is 36% versus 6% in investigator's choice, and 18 months PFS is still 24%. Next. Overall safety, it is largely tolerable. Grade 3 nausea is seen only 6 patients, so which is only 2.5%. Dose reduction required due to nausea in only 3 patients, so it is a largely tolerable drug. Apart from some nausea, it doesn't do any severe AE or SAE. So we can use same as our routine hormonal treatment. No hematological safety signals required, and no any case of sinus tachycardia or bradycardia reported with this drug. Next. So second abstract is Capitello 291, which is capivasertib plus fulvestrant versus placebo plus fulvestrant in AI-resistant, hormone-positive, HER2 negative advanced breast cancer. In this, apart from advanced breast cancer, metastatic breast cancer patients, patient who has taken less than 2 lines of hormonal treatment or less than equal to 1 line of chemotherapy for advanced breast cancer are taken into the study. Apart from these, AKT, mTOR, PICK3 pathway mutation is also taken into consideration. Around 708 patients are enrolled in both the arms. 335 in capivasertib arm versus in placebo arm, 353 patients are enrolled. Dual primary endpoints are PFS in overall population as well as in patients with AKT pathway altered tumors. Key secondary endpoints is overall survival and overall response rate in all the population as well as in patients with AKT pathway altered population. Next. Baseline characteristics, particularly in study arm, 43% of the patients has AKT pathway alteration versus 38 patients in placebo arm. Apart from these PIK3 mutation, AKT1, PTEN, all the pathways are taken into consideration, and according to them, they were divided. Next. In this Kaplan-Meier, we can see that PFS is 7.2 months in study drug versus 3.6 months in placebo group. So those patients who have taken capivasertib plus fulvestrant, PFS was good as compared to placebo arm. Next. Same in also patient with AKT pathway those patient has AKT pathway alteration. PFS is 7.3 months versus 3.1 months in placebo arm. So we can say that if patient has AKT pathway alteration or in overall population, capivasertib plus fulvestrant combination has better response as compared to placebo versus placebo plus fulvestrant. Next. In overall, when we see overall PFS, it favors the capivasertib plus fulvestrant group even in patients with liver metastasis and those patients who have taken prior CDK4/6 inhibitors as compared to placebo versus placebo plus fulvestrant. Next. When investigator assess the response, overall response rate in study group is 22% versus only 12% in placebo group in all the population, and all the other objective response like complete response, partial response, stable disease are very beneficial for the capivasertib plus fulvestrant group as compared to placebo population. Even progression of the disease seen in 23% of the study group versus 42% in placebo. So progression chances is higher in placebo arm as compared to study group. And same in AKT pathway altered patient. Complete response, partial response, and progression of the disease, all the parameters favors more for the study drug as compared to the placebo. Next. Overall survival. Overall survival is clearly beneficial for the study group as compared to the placebo. And here we can see this with Kaplan-Meier. Overall survival data at 28% maturity. This is at 28% maturity in overall population. Next. Safety. This is largely tolerable drug. Still, some patients get acute MI, cerebral hemorrhage, aspiration pneumonia, and sepsis in study drug. But as per to investigator, is not related to the drug. This severe adverse event is seen in only 5 to 6 patients. Otherwise, it is largely tolerable drug. Next. Adverse events like diarrhea, nausea, rash, fatigue, vomiting, headache. These are the common adverse event we can see in patient with study arm. But majority of the patient has only grade 1, so it can easily manageable with normal medication or counseling. Dose interruption or withdrawal is not required. Next. Thank you. So we are hoping for getting new medications for the hormone positive breast cancer. Let's see when we can use in our day-to-day practice.
Thank you, Dr. Palak Bhatt. I think we have more and more drugs in the armamentarium of hormone positive breast cancer. and I hope these drugs would be soon available for Indian population also. Moving to our next talk, I would like to welcome Dr. Ekta Wala Chandarana, who is consultant medical oncologist and co-founder of Medisquare Super Specialty Hospital and Research Institute, Ahmedabad. She is going to present two abstracts. First is about TROPiCS-2, that is sacituzumab govitecan versus investigator's choice in hormone positive, HER2 negative metastatic breast cancer. And our second abstract would be STICK CTC, that is first line circulating tumor cell driven treatment versus investigator's choice in hormone positive, HER2 negative breast cancer. Over to you, Dr. Ekta Wala Chandarana.
My screen is visible.
Yes,
Yes.
ma'am, it's visible.
So thank you, Team Oncowin, for inviting me for this session. We are going to discuss today these two abstracts as spoken by Dr. Hitesh Khatwani. So we all know hormone positive, HER2 negative disease is the most common subtype of metastatic breast cancer. Treatment includes sequential endocrine therapy combined with a targeted agents followed by single agent therapy with increasingly shorter durations of the benefits. SG, sacituzumab govitecan, is an anti-TROP2 antibody drug conjugate approved for the metastatic triple negative breast cancer treated with more than 2 prior lines of therapy. The hormone positive HER2 negative MSC cohort of the phase 1 or 2 IMMU 13201 study had an objective response rate of 31% with this drug, median PFS of 5.5 months and median overall survival of 12 months with a manageable safety profile with SG. So what is TROP2? TROP2 is a transmembrane calcium signal transducer, is highly expressed in metastatic breast cancer patients and plays a role in tumor growth and progression. SD is a novel antibody drug conjugate comprising an TROP2 antibody coupled to SN38, the active metabolite of irinotecan, via a linker. So TROPiCS-2, it's a randomized multi-center open label phase 3 ongoing study. In this trial, they have taken patients with the metastatic or locally recurrent, inoperable, hormone positive, HER2 negative breast cancer patients with disease progression after one or more than one line of endocrine therapy, Taxane and CDK4/6 inhibitor in any setting. 2 to 4 previous lines of chemotherapy was allowed. They have randomized, they have taken total 543 patients and they have randomized in the 2 arms. One is with the sacituzumab govitecan, that is the dose is 10 milligram per kg IV on day 1, day 8 to repeat every 21 days. And the another arm was a physician choice of treatment in which they have allowed a capecitabine, vinorelbine, gemcitabine or eribulin. The treatment was continued till progression or unacceptable toxicities. Primary endpoint was PFS and objective response rate, and the secondary endpoints were OS, duration of response, clinical benefit rate, patient reported outcome, and safety. So current exploratory analysis evaluated impact of TROP2 expression on the efficacy based on this histochemical score using the archival tissue. So here we can see the majority of the patients, almost more than 90% of the patient had visceral mets. More than 60% of the more than 80% of the patients had received prior endocrine therapy for more than 6 months, and roughly around 60 and 40% of the patients had received prior CDK4/6 for less than or more than 12 months of the duration. So if we see the results, median PFS was 55.5 months versus 4 months, favoring the SG with the hazard ratio of 0.66, that is statistically significant. And the 6-month PFS was 46% versus 30%. Median overall survival was numerically higher with SGM, that is 13.9 months versus 12.3 months. Which was not statistically significant. Overall response rate was 21% versus 14%, and clinical benefit rate was 34% versus 22%. If we see the adverse event, grade 3 or higher was seen in about 74% of the patients with SG versus 60% of the patient with TPCM. And among the adverse event, majority patients had neutropenia and diarrhea. Treatment discontinuation rate was 6% versus 4%, and 1 patient died in the SG arm because of the treatment. So this membrane TROP2 expression was determined on the primary or metastatic archival tumor tissue by IHC and expressed as a histochemical score, that is the H score. The range was from 0 to 300, and they have segregated these patients based on the score, less than 100, more than 100, or in less than 100 to they have divided in between less than 10 or more than 10. So here we see the PFS by TROP2 expression level. We can see the PFS favoring SG was there in almost each and every subgroup. In the PFS advantage was there. It was with PFS advantage was there irrespective of this H score. But we have to take this data very cautiously, as the sample size was very small. If we see the overall survival, again the median overall survival was favoring SG irrespective of the H score. Even in patients with H score less than 10, the overall survival was 17 months versus 12 months favoring the SGR. So if, here we see the responses similarly observed in TROP2 negative subgroup 2. Responses observed in all the TROP2 subgroups. To conclude this trial, SG had a statistically significant, clinically meaningful PFS benefit over single agent chemotherapy and a manageable safety profile in the patient with heavily pre-treated hormone positive, HER2 negative, endocrine resistant, unresectable, locally advanced or metastatic breast cancer who have limited treatment options. Exploratory analysis confirmed efficacy of the sacituzumab govitecan across all the TROP2 expression levels, even those with very low expression in this subgroup. Investigators concluded that TROP2 testing is not required for SG treatment. So we'll now discuss about second trial, STIC CTC trial. So we all know the clinical validity of the circulating tumor cell has been established since many years. The validity of the CTC count as a prognostic marker was first reported in 15 years ago. This CTC count has reached to level 1 evidence as a prognostic marker, and multivariate analysis confirmed that 3 prominent prognostic markers in the patient with MBCs are tumor subtype, performance status, and baseline CTC, circulating tumor cell count. So in a population with hormone positive, HER2 negative MBC with homogeneous performance status, baseline CTC count may be a more reliable, standardized, and reproducible prognostic factor than the characteristics commonly used by us to drive our clinical decisions. So it's a randomized open label non-inferiority phase 3 trial conducted at 17 sites in France. So pre or post-menopausal women with newly diagnosed hormone positive, HER2 negative patients were taken. So patients were given treatment, endocrine therapy or chemotherapy, depending on the whether they are in a clinical criteria arm or they are in a CTC arm. So patients were treated with endocrine therapy if the circulating tumor cell count was low, that is less than 5 per 7.5 ml. And if they were given chemotherapy if the CTC count was high, means more than or equal to 5 CTC per 7.5 ml in a CTC arm. In clinical arm, endocrine therapy was given where the patients were not in a visceral crisis, where clinically low risk patients were there, and chemotherapy was given in a clinically high risk patients. Primary endpoint was PFS. So total they have taken 778 patients were randomized, and in the clinically driven treatment choice arm, total 378 patients were there. Here we see the almost 1/3 of the patients were showing discordant report, like they were clinically high, but the CTC was low, and they received chemotherapy. And in the other arm, 391 patients, and out of them 239 patients were CTC low and received endocrine therapy, but 138 patients were CTC had received CT. And here we see the baseline characteristics. We have discussed 80 mostly AI therapy or fulminant was given, and in chemotherapy they used paclitaxel or capecitabine in majority of the patients. CTC was done in clinically driven arm, but it was masked before randomization. So now if we see the results in all the patients, whether patients were treated with the CTC criteria or clinical criteria, PFS and OS were not different. They all both are the same. So non-inferiority was established as it's a non-inferior trial. Now, if we see or talk of a subgroup where we see the clinical low and CTC low patients, were around the 48.2% of population, and here also the median PFS is 17.4 months versus 19.5 months, and median overall survival is also similar in both the arms. Here now, if we see the clinically high and CTC high patients, then again they were treated with the chemotherapy, and median PFS and OS was not different. So now if we see the results in clinically low but CTC high patients, it consists of 25% of the population, and in this population, here we see the PFS is 15.7 months versus 10 months, favoring the CTC arm. So these patients were treated with the chemotherapy in CTC arm, but they were treated with only endocrine therapy in the clinical arm. So in this population where clinically we think that patient is not a candidate for chemotherapy, but CTC is high, then these patients, when treated with chemotherapy, they get advantage with the chemotherapy in terms of overall survival and PFS. And again, in clinically high but CTC is low, there was no difference in both the arms as for PFS and OS. If we see this fluorescent plot chart, all the subgroups when compared, only this subgroup which is clinically low but CTC high, there only the results were favoring the CTC arm. So again, this 189 patients who were clinically low, CTC was high, and in that case, it favors the treatment based on the CTC counts. So there was a limitation of this study. The study was conducted before the results of the first-line CDK4/6 inhibitors pivotal trials, which is now the standard of care in first-line setting. But it was not given in this trial. Although the CellCert system is the only FDA-cleared CTC detection technology for MBC, some mesenchymal-like cells CTC may be missed. So to conclude my second abstract, it's a first prospective trial supporting the clinical utility of CTC count in hormone-positive HER2-negative MBC for clinically low but CTC high patients. Median overall survival benefit was there of 16 months with chemotherapy versus endocrine therapy alone. For clinically high CTC low patients, overall survival advantage was not there with chemotherapy, so ET remains the standard of care. So choice of ET versus CT still is unclear for the patients who received CDK4/6 inhibitor as a adjuvant or first-line therapy. And this trial, the results of this trial demonstrate the reliability and clinical utility of CTC to guide the choice of treatment as a first line, but at the cost of higher proportion of the patients treated with chemotherapy in CTC. On the other hand, 48 on the other hand, clinically low and CTC low patients, which were around 48% of the patients, have an excellent prognosis with the 18-month median PFS and OS, 18 months of median PFS and 50 months of median overall survival. Thank you.
Thank you, Dr. Ekta Awala-Chandrana, for your wonderful insights on these two abstracts. I think circulating tumor cells and antibody drug conjugates are definitely a long way to revamp the management of breast cancer in near future. For next session, I would like to invite Dr. Gaurang Modi, who is co-founder and consultant medical oncologist at Oncowin Cancer Center, Ahmedabad. We'll be talking about redefining life for a challenging hormone-positive, HER2-negative metastatic breast cancer patient. And academic partner for this session is Novartis. Over to you, Dr. Gaurang.
So am I audible?
Yes.
Okay. Thank you for the kind words and good evening and warm welcome to everyone. At the outset, I would like to thank you, Novartis team, for providing me slides and material. And the stage is already set by multiple eminent national speakers. So without wasting much time, I'll start my talk, and in next 15 to 20 minutes, I'll be talking regarding the redefined role of ribociclib in HR positive, HER2 negative metastatic breast cancer patients. So let's get started. So basically, it's a cliche to say that HR positive, HER2 negative breast cancer comprises 2/3 of all breast cancer patients. And as we study endocrine therapy with the basic, that is aromatase inhibitor, anastrozole, and exemestane, letrozole, with tamoxifen and fulvestrant as a baseline therapy, and then advent of CDK inhibitors, mTOR inhibitors, and that ESR1 and AKT inhibitor that described by Dr. Palak is they are on the way. And with all this, we have chemotherapy backbone. For which purpose? The purpose is clear. We want to achieve a best overall survival for our patient with better progression-free survival with all this better quality of life. So basic gamut of HER2, HR positive, HER2 negative MBC patients are usually in a first line setting. Combined with CDK plus AI is the standard of care. If patient is not affording, then we can use a first line as a first generation endocrine therapy like tamoxifen, fulvestrant, and AI. And with progression, if PIK3CA mutation positive, then we can use alpelisib plus fulvestrant. If it is a PIK3CA mutation wild type, then we can use fulvestrant. And if you want to use a chemotherapy for a special subset of patient, that is heavy burden disease or a visceral crisis, then chemotherapy options are there. But the main thing is that we have limited options regarding the visceral crisis. And at present, combined chemotherapy is the only option available if patient has a visceral crisis. And if we see that the visceral crisis definition has evolved as the time passes, as we can see that in ABC3 guideline, defined visceral crisis like a visceral crisis is not a mere presence of visceral metastasis, but there are a vague definition at that time. But now it has remained, they have defined a more refined definition of visceral crisis. They have classify as a liver visceral crisis, lung visceral crisis, and they have put a specific point to define the visceral crisis definition. And we all know that if patients comes to you with the visceral crisis or heavy burden disease, we are inclined to use multi-agent chemotherapy first to get better response and improve the quality of life of the patient at early. But at the same time, we know that the chemotherapy has its own demerit of decreased quality of life of the patient. And there are limited data available about the sequential agents. So at present, we don't know how to proceed when the patients come with the visceral crisis. And there are limited data about using CDK4/6 inhibitor with AI or AI fulvestrant or upfront using upfront using combined chemotherapy for visceral crisis. So at present, we can say that if patient is not in a visceral crisis, we definitely use CDK4/6 inhibitor with AI, and all the trial suggests that there is a better PFS advantage if we use CDK plus AI. So if I thread out all three CDK inhibitors into one table, this is a table. So regarding the first palbociclib has main two landmark trial, Paloma 2 and Paloma 3, and both trial met its primary endpoint, that is PFS. But if we see the Palomar 2 overall survival that was published in October 22, suggests that the overall survival is not significant, except some patient has a disease-free interval more than 12 months that have shown the OS of approximately 66 months. And again, the survival data were missing. So we can say the Palomar 2 trial overall survival has not met. If you see the Palomar 3 that enrolled the patient first line as well as the second line, and they used fulvestrant with the palbociclib. And again, the overall survival data, that is intention to treat patient analysis, OS is not met, but the per protocol analysis, that is hormone sensitive disease, the OS is there. Regarding the abemaciclib, there are two landmark trial, Monarch 2 and Monarch 3. Both trial made the primary endpoint of PFS. But again, the overall survival for the Monarch 3 is not a statistically significant, that is recently published. And I think the Abema is a new drug, and we should wait for the new data and mature data to come. But regarding the ribociclib, we have the at present robust data for all three trials are there. There is MONALEESA 2, MONALEESA 3, and MONALEESA 3. All three trials met the primary endpoint of PFS, and all three trial at present suggest that there is a meaningful overall survival benefit with the ribociclib is there. And this is not all hunky dory with CDK inhibitors. The advantage comes with some disadvantage of side effects, like in ribociclib arm, usually some sort of neutropenia, QT prolongation. In palbociclib arm, we have used as a neutropenia is the most common side effect. And in Abema arm, diarrhea is a bit concern with recent real world data suggestive of thromboembolic events, that is double compared to that were shown in the clinical trial. But usually the side effect is clinically manageable with all CDK inhibitors. And if we see the quality data regarding the patient's quality of life, ribociclib, according to MONALEESA 2, 3, and 7, outperforms other CDK inhibitors. Regarding the selective inhibition of CDK4 and CDK6, the better and unique characteristic of ribociclib helps for the better selective action on CDK4 and CDK6 receptors. If we see the pooled analysis of all the MONALEESA study regarding the heavy burden disease, some visceral metastasis patient, and metastatic stage more than 3, these are the patient if we enroll and pooled and done a pooled analysis, there were some extra benefit is with ribociclib as shown. And in premenopausal woman, that Dr. Manjari ma'am has brightly pointed out that Asian patients are more perimenopausal, more younger, and presented with the more advanced stage. That's why they were very aggressive compared to Western outcome. So we need more data regarding this subgroup of the patient. So and this type of aggressive HR positive, HER2 negative patients are not prospectively studied regarding the use of CDK4/6 inhibitor with AI versus chemotherapy. So there is an unmet need at this subset of the patient, and this is the data that was presented in San Antonio Breast Cancer Symposium in December 22, and that is shown by Yansen Lu from Taiwan, and this is the right choice trial. Is a phase 2 randomized control trial that have enrolled pre and perimenopausal women with HR positive, HER2 negative, advanced breast cancer patient, and they have enrolled specifically aggressive disease, that is symptomatically visceral metastasis with rapid disease progression or impending visceral compromise and markedly symptomatic non-visceral disease. They have enrolled a visceral crisis patient according to the ABC3 guideline at that time, and they have stratified the patient according to presence or absence of the liver metastasis with disease-free interval less than or more than 2 years. And they have randomized 1:1 basis. First group had received ribociclib plus AI with goserelin, and other cohort had received a physician choice chemotherapy. And the primary endpoint, as usual, PFS. Secondary endpoint was time to treatment failure, time to respond, overall response rate, clinical benefit rate, and ultimately OS. That is the I want to show you so that in ABC3 the visceral crisis definition was different compared to ABC5. There is a defined guideline and definition of visceral crisis is there. So here the baseline characteristic were well matched, and if I thread out the data, they have selected more than 85% patients that are ER positive, but the ER percentage was more than 50%, right? And they have selected almost more than 85% patients that are PR positive, and they have already enrolled liver lung metastasis patient. And here point to remember is they have enrolled 50% patient of visceral crisis, that is in concordance with the new guideline. So coming to the result, that is significant PFS advantage with Ribo plus AI arm compared to chemo arm in visceral crisis patient. If we speak about a specific data, that there is 24 month versus 12 month, is absolute delta that we can get is 12 month, and you can say there is clear cut separation of the Kaplan-Meier curve. And we always think that chemotherapy has a better overall response rate, treatment time to treatment response, and also clinical benefit rate is better with the chemotherapy. But this trial has broken this myth that the overall response rate and clinical benefit rate is similar to chemotherapy, and time to response, that is initiation of the action with chemotherapy and with Ribo with AI, is similar. And if we see the forest data, most of the subgroup has inclined regarding the use of ribociclib plus AI. And median time to failure, usually it corresponds to the PFS, and median time to failure is regarding the Ribo plus AI, it approximately 19 months compared to chemo arm, it was 9 months, and that is also statistically significant. And if we see the side effect profile, the chemo arm has a less quality of life and more side effect compared to Ribo plus AI arm. There is significant less toxicity in Ribo plus AI arm compared to chemotherapy. So to conclude that ribociclib has already shown his robustness in multiple Mona Lisa phase 3 randomized trial, and the PFS advantage is significant with the old trials, and also there is OS advantage. And this trial is a prospective randomized trial, has shown that ribociclib can work in high tumor burden, visceral metastasis, and aggressive disease. And here, if we compare Ribo plus AI in those high burden cases, we can achieve 1 year extra PFS compared to chemo with similar overall response rate and clinical benefit rate with time to response rate. So if some caveat of this bright choice study is there, again, the number is small as there is a phase 2 data, and 2 point is very significant is that what about the ER positive patient, that ER percentage is less than 50%, and what about the disease free interval that is less than 2 years. So if there is inherent biology is bad, overall PFS would be bad. And again, the ribociclib has proven the quality benefit, and it outperform other CDK inhibitors. Thank you very much.
Thank you, Dr. Gaurang Modi. So now probably we have more stronger data to support hormonal therapy and specifically ribociclib for patients with visceral crisis with this right choice data. Moving ahead for the next session, I would like to invite Dr. Rushabh Kothari, my colleague and co-founder at Oncovin Cancer Center, Ahmedabad. He will be talking about decoding the overall survival of Palomar 2 study with palbociclib, and academic partner for this session is Pfizer. Over to you, Dr. Rushabh.
Thank you, Dr. Ritesh. Geetika, can you share slide? Thank you. So after a great talk on ribociclib, I would be defending palbociclib. Why there was no overall survival benefit in Palomar 2. Next slide, please. Next slide, please. So as we are aware that PFS being primary endpoint in most of the trials, PFS was significant in all the first and second line trials, and with a impressive hazard ratio, right from 0.45 to 0.6. But in overall survival, not all trials had that impressive overall survival hazard ratios. Some crossed unity too. Next slide, please. So as Dr. Gaurang also showed that each CDK4/6 inhibitor have some difference in affinity to CDK4/6 or some other CDK cyclin combination. So this is a plot for the same. Here we can just know that CDK4/6 are largely inhibited by all three of them in a good fashion. Abemaciclib probably has effect on other cyclin also. Next slide, please. So I will be presenting, next slide, please. I will be showing overall survival with first line palbociclib plus letrozole versus placebo plus letrozole in women with ER positive, HER2 negative, advanced breast cancer, analysis from Palomar 2. Next slide, please. So palbociclib was first CDK4/6 inhibitor to be approved, and in the phase 3 study which was presented, we are aware that there was a PFS benefit of 24.8 months versus 14.5 months, and PFS was the primary endpoint. At the time of PFS analysis, OS data was not mature. So in ESCO 2022, they presented overall survival data after a median follow-up of 90 months. Next slide, please. So this is the design of Palomar 2. Postmenopausal patients with ER positive, HER2 negative, no prior treatment for advanced disease, ECOG performance status 0 to 2, 2:1 randomization, palbase plus letrozole versus placebo plus letrozole. Primary endpoint was investigator assessed PFS. Secondary endpoint was OS response safety biomarker. So here we will discuss largely on overall survival. Next slide, please. So statistical assumptions was that there will be a 44% improvement in median PFS from 9 months to 13 months. Next slide. And for OS, the statistical assumption was that there will be a improvement from 34 to 46 months. So based on that assumption, the calculation of data set was 390 events would be required for hazard ratio of 0.74. Here we had 80% power with one-sided alpha of 0.025. Next slide, please. So this is a PFS slide both the original one and then the updated one. The updated one, the PFS for palbociclib plus letrozole is 27.6 months versus 14.5 months with a good hazard ratio, confidence interval not crossing unity. Next slide, please. So now, what were the issues? Why overall survival didn't came? So there was a significant missing data in both the arm, palbociclib arm and placebo arm. Unfortunately, the placebo arm has more missing data. Around 21% of the data was missing compared to 13% in palbociclib arm. Next slide, please. Here we can see that around 10% patients are still on the same treatment at around 90 months in palbociclib plus letrozole arm versus only 2% in placebo plus letrozole arm. Next slide, please. So this is the overall survival data which was presented. Palbociclib plus letrozole 53.9 months versus 51.2 months with palbociclib placebo plus letrozole. Hazard ratio of 0.956, confidence interval crossing unity, and p-value is not significant. So here the placebo plus letrozole arm had median overall survival of 51.2 months, while our assumptions during statistical analysis was it was around 34 months. So this is something which will also affect because sample size would be smaller than what we was smaller than what we assume. See that. Next slide, please. So now if you see the discrepancy in ECOG performance status 0 group, this group had maximum discrepancies. So missing data was 11% versus 28%. And if you see median overall survival in placebo plus letrozole arm, it was 85.9 months, which was like never heard of in metastatic hormone positive disease. So probably the missing data is causing the difference in overall survival is one hypothesis. Next slide, please. If you see the groups where missing data is similar in both the arms, largely everything is favoring palbociclib plus letrozole rather than placebo plus letrozole. Again, hypothesizing that probably missing data has a role to play in. Next slide, please. So the post-hoc analysis where they excluded patients where data of survival was missing, they saw that overall survival improved a bit, 51.6 versus 44.6 months. Again, this is not statistically significant still. Next slide, please. So though numerically it was better, but it was not statistically significant even after you remove the missing data. Now, when you combine Paloma 1 and Paloma 2 data, you can see that in patients with disease-free survival of more than 12 months, so these are the endocrine sensitive patients. Side one. The overall survival difference was 64 versus 44.6 months, and which was significant. The question is, can we dig the data so much to get significance is something. Next slide, please. Again, this is important that post second line treatment, CDK4/6 inhibitor was received only in 27% of the population in placebo arm. Next slide, please. Time to chemotherapy was extended when you give Palbase plus letrozole, and this was statistically significant. Next slide, please. Now, the difference between three trials, one with ribociclib, one with abemaciclib, and one with palbociclib. If you see the patients with endocrine resistance, 22% patients were taken having secondary endocrine resistance in Paloma 2, It was not allowed in Monarch 3, and Mona Lisa 2 had only 1% of such patients enrolled. So probably Paloma 2 also had more endocrine resistant population than the other trials. Next slide, please. So again, the same point, you can see that disease-free interval of less than 12 months was highest in Paloma 2. And in rest of the trials, you can see that disease-free interval of more than 12 months, it is more than 50% in all the Mona Lisa and Monarch trials. Next slide, please. So even for disease-free interval less than 12 months and more than 12 months, you can see that hazard ratio for PFS is similar. But in overall survival, the hazard ratio is different. Again, pointing that probably the missing data, 12 versus 29% missing data, the discrepancy is something which is playing a role. Next slide, please. Again, important point is that whenever more than 20% population is lost to follow-up, statistically, it poses threat to the validity of data. Even more than 10% is something which can bring in biases, but more than 20% is a serious threat to validity of data. And here in placebo arm, we have 21% missing data. Next slide, please. So next slide, these are the toxicity profile which we all are aware of. So for Paloma 2, the conclusion would be it meets its primary and the safety profile of palbociclib plus letrozole, as we all know, as we all have used, and now most of our patients are on it. So we are all aware that it has good efficacy profile, safety profile, quality of life is well maintained. Next slide, please. Next slide, please. So overall survival was numerically longer, but statistically not significant. The points which we need to ponder on are whether more endocrine resistant population was there. There was discrepancy between placebo and PAL-based group where missing data was discrepant. That is something which we need to look at when we see overall survival data of Paloma 2. Next slide, please. Next slide, please. So this is real world evidence which was presented in ESMO Breast Cancer 2022. This is a huge database of 3 million patient records, and it is across academic and non-academic center, and it has been extracted from a software. So the validity is good. Next slide, please. What they did with this database was statistically they had two level of analysis. First was unadjusted analysis, and then second was after stabilized inverse probability of treatment weighting and propensity score matching. So leaving the jargon, they tried to simulate as if it was a randomized trial, and they applied these two statistical parameter and tried to make the population similar in placebo versus PAL-based arm. Next slide, please. So here you can see that when they have done statistical manipulation, they can make both the population uniform. Next slide, please. Next slide, please. And after statistical analysis or statistical manipulation with both the methods, you can see that hazard ratio is 0.72 for overall survival and not crossing unity, and P value is significant. Next slide, please. And this was seen across most of the subgroups. Next slide, please. And if we did this statistical manipulation in PFS, again, we had PFS benefit, which was statistically significant. Next slide, please. So overall message from PREALITY X is that real world evidence also favors palbociclib, and it looks like there is overall survival benefit if we do the statistical manipulation to make both the population similar. Next slide, please. Again, based on EMR data, the palbociclib has been approved even in male breast cancer patients for hormone receptor positive and HER2 negative. Next slide, please. We have few, rather 4 to 5 Indian data for palbociclib. Next slide, please. The first one is for 188 patients. Next slide, please. Where median PFS was around 20 months in first line and around 12 months in second line, with overall response rate of 80%. Saying that efficacy in Indian population is also similar to what it is in Western population. Next slide, please. Similar data was replicated. The median PFS was not reached at ongoing follow-up of 38 months with Palbase plus letrozole, and median PFS in second line was 14 months. Next slide, please. The third study showed that median PFS is 18 months, and again ensuring that 1 year PFS of 73.7% and 1 year overall survival of 89.2%, showing that efficacy is similar in Indian patients. Next slide, please. This is again a study from Jaipur, and this is study from Dr. A.K. Vaid group, which shows that efficacy of palbociclib is reasonably good even in Indian patients. Next slide, please. So summary from Paloma 2 plus P-Reality X and from the Indian data, it looks like the PFS is significantly better with palbociclib. Overall survival is numerically better in Paloma 2, but not statistically significant. But in P-Reality X, we could see that if you match the population, overall survival was better. Real world experience with palbociclib, even in Indian setting, shows the efficacy and tolerance both. So as per most of the guidelines, with endocrine therapy are standard of care for patients with hormone receptor positive, HER2 negative patients. I think this is the last slide. Thank you.
Thank you, Dr. Rushabh, for giving new angle to the survival data of Paloma 2. I think we will move ahead for the last session of the day, which is a panel discussion. I would like to invite the moderator, Dr. Gaurang Modi, my colleague and co-founder of Oncovin Cancer Center, Ahmedabad. He will be moderating the session on revamping the landscape of hormone positive, HER2 negative MBC in 2023. Meanwhile, I would like to invite the panelists, Dr. Kalpesh Prajapati, who is a consultant medical oncologist at Hemato-Oncology Clinic, Ahmedabad, Dr. Chirantan Bose, who is Chief Molecular Pathologist and Director of One Cell Diagnostics and Index AI, Dr. Jay Dadania, who is a Consultant Medical Oncologist at Sterling Hospital, Ahmedabad, Dr. Irapa Madhabavi, who is Consultant Medical Oncologist at Kirudi Cancer Center, Bangalore, Dr. Ektawala Chandrana, Consultant Medical Oncologist at Medisquare Super Facility Hospital and Research Institute, Ahmedabad, Dr. Ankit Agarwal, who is a Consultant Medical Oncologist at Geetanjali Hospital, Udaipur, Dr. Jignesh Rajavanshi, who is a Consultant Medical Oncologist at SIMS Hospital, Ahmedabad, and Dr. Sanjay Gandhi, who is a Consultant Pathologist at Histopus Diagnostics and Shelby Hospital, Ahmedabad. I would just like to request Geetika that if any panelists is missing, then do let us know. Over to you, Dr. Gaurang.
Okay. Are my slides moving?
Yes.
Yes, sir.
Yes,
It's moving.
Just a second. Okay. Thank you for the kind words, and good evening and warm welcome again. So the topic that is given to me is revamping the landscape of HR positive, HER2 negative metastatic breast cancer in 2023. And we have the highly esteemed and learned panelists. We have 6 medical oncologists in our board. I think Dr. Kalpesh is not there. And one histopathologist, Dr. Sanjay Gandhi, and Dr. Bose is a molecular pathologist. So let's get started. So basically, in the arsenal of HR positive, HER2 negative breast cancer, we have hormonal therapy as a first generation, AI, tamoxifen, fulvestrant with novel agent, that is CDK4/6 inhibitor, PIK3CA, AKT inhibitors, that is described by Dr. Panak. AMTO inhibitors is not new. PARP inhibitors are there, and all with this, with the standard chemotherapy protocol. So are we shifting from single agent endocrine therapy to dual agent endocrine therapy plus CDK4/6? So that is the real world data from Europe that is published recently, and it suggests that before the advent of CDK inhibitors, that orange bar showing that almost 60% of patients were being used upfront chemotherapy by oncophysician compared to AI or CDK4/6 inhibitor, but gradually it has shifted. And if you see that recently there is published data, the dark blue bar, almost 60% patients were being used CDK4/6 inhibitor compared to only 10 to 15% patient were being treated as upfront chemotherapy. So with this background, I would like to present my first case, 47 female with no comorbidities and one maternal auntie had a CF breast in a family history at the age of 54, echo PS1, and she has been diagnosed as a CF breast in January 2013 at the age of 37 years. So with the usual case, post-MRM, T2N1, HR positive, HER2 negative, patient was being offered chemo, local RT, and then she was given tamoxifen for 7 years and total completion of treatment in September 2020. So now at present, she is presented with right hypochondriac pain for 15 days and sonography suggestive of some space occupying lesion of 3 to 4 centimeter in liver. So how would you proceed? So I would like to start with Dr. Jai. Jai, how would you proceed with this case?
Yes, so Gaurav bhai, I would like to do the biopsy from the liver lesion along with the ERPR HER2 status, and then I will do the PET CT of that patient. And I also recommend her to do the BRCA testing because she is the ideal candidate for that.
All right. So the biopsy from the liver lesion suggestive of IDC with strong ER positivity with PR 10% and HER2 negative. And PET suggestive of liver metastasis comprises of 3 lesions. Lung lesions were there, 3 to 4 tiny lesions. Fluid tapping was required one time and it was cytopositive. At present, there is no display of exertion and mild cough is there. And baseline LFT, RFT and CBC is normal. No CNS symptom. And BRCA comes to negative. So how would you proceed? Dr. Ekta?
Considering a young age, so 46 year, I think female, so ovarian suppression is to be done.
Right.
And with that, aromatase inhibitor and CDK4/6 inhibitor combination treatment.
Right. So what would you offer for OFS? Medical or surgical?
I usually offer medical ovarian suppression.
Right. So any role of PIK3CA testing or any broad NGS panel right now?
Definitely, we can, at the present, we can do PIK3CA testing, not on a broad NGS panel, but on a single, as a, we don't want to know so many mutations at this time. So solo testing can be done.
Yes, all right. Because in PIK3CA data is only in a second line, so we better use in a second line setting, and broad panel NGS should be done usually in a second line setting. All right. So before rolling out the treatment, is it a endocrine sensitive case or a precision case? Dr. Pirappa? Pirappa is there?
Yes, sir. And as according to the definition, if it is more than 2 years in metastatic setting, she comes under the endocrine sensitive case only.
Right.
She has completed in 2020 and now presented in 2023, means more than 2 years. Yes.
Right. So, Dr. Virappa, it is a endocrine sensitive case, right? But and with patient has visceral metastasis there. So, is it overwhelming visceral crisis or only a simple visceral metastasis? So, what do you think? Looking at this case.
As she is not having any shortness of breath, any organ dysfunction right now. So maybe this case is we consider it MBC only with visceral metastasis, not visceral crisis.
All right. So with updated visceral crisis definition, according to ABC5, that have clearly defined the role of visceral crisis in the management of metastatic breast cancer. That is lymphangitis, carcinomatosis with dyspnea at rest. That is not characterized by pleural effusion, cytopenia with bone marrow involvement, diffuse liver metastasis with liver function impairment, that is bilirubin more than 1.5 milligram percentage, and is not explained by any Gilbert or biliary tract obstruction, and patients should be symptomatic for leptomeningeal metastasis or SVC syndrome. And we know that if such kind of patient comes to in your OPD, we usually incline to start chemotherapy upfront, because overall prognosis of that patient is poignant and survival would be in a month, like 3 to 4 months. So my question to Dr. Jignesh, so do you change your treatment decision according to the percentage of PR positivity with ER/PR negative? So let's say if patient has PR percentage 5%, ER and HER2 negative, or another patient which has PR 15% with ER and HER2 negative. So according to you, this patient is different, or you would consider same?
Yes, it is different. Actually, if ER negative, HER2 negative, and PR 5%, then I would like to prefer to go with chemotherapy. But if PR is 15%, then I would like to go with hormonal therapy.
Perfect. So as Dr. Jignesh has brightly pointed out, and this significance of PR positivity is according to ABC6 guidelines suggests that if PR is more than 10% with ER/PR negative, we can try hormonal therapy or dual CDK plus AI. But if patient is ER and HER2 negative with PR is of less than 10%, then this result should be discussed with the pathologist, or retesting should be done. And if it is less than 10%, then it considers a triple negative breast cancer. So my question is, my question to Dr. Sanjay, so what are the different methods of scoring ER/PR? So usually we are seeing such kind of report like ER positive and in a percentage, and usually is a kind of a H score. But there is a new word is also there is an ALRED score. So so what is the difference between H score and ALRED score?
Actually, according to the ASCO-CAP guideline, 1% tumor cell is considered positive.
All right. Yes.
Now, CAP has mentioned 2 guidelines for quantification. The purpose of quantification is more the percentage of tumor cell, more chances that patient will respond to hormone therapy.
Right.
Now, there are 2 systems. One is ALRED and one is H score. In ALRED score, there is a SWAMI quantitation of tumor cells positive, and with intensity, they are sum up. So score will be 1 to 8. Score is higher, more probability that patient will respond to hormone therapy. but there is only one point in Allred score. If tumor cells are less than 1% positive and intensity is strong, then Allred score will come 3. And they are considered positive as a Allred score. But as per CAP ESCO guideline, they are negative. Such proportions are very small, and their response to hormone therapy is not well proved yet. While in H score, even single cell with small intensity will considered as score 1, and they are considered positive. So these are the just little bit drawback of Allred score over H score.
Okay. And what about the H score method?
H score method, we exactly quantify the percentage of tumor cells, and that we multiply with intensity. If intensity is strong, we consider 3+, moderate 2+, and low 1+. And they will be multiplied and score will be given out of 300. Suppose 50% cell strong positive, the score will be 150 out of 300. More the score, more chance patient will respond to hormone therapy.
So usually that the reports that we are getting in Ahmedabad, according to my knowledge, usually the X score is counted, right? And
Yes.
Allred square is not counted. So is any specific reason for that?
No specific reason. We can mention both the method also, but just one drawback of Allred score, as I say, score 2 and 3, which comes positive in Allred score, will turn out to be negative by CAP ESCO guideline and H score.
All right. So why am I stressing on Allred score? There's a recent publication that is regarding the in subset analysis of PADA trial, and they have found out that the PFS is significant change according to the percentage of ER/PR status, and they have counted a Allred score. And if you see, there is significant discrepancy according to the ER/PR percentage. And if ER/PR percentage is less than 50 to 80, and more than 80%, there is significant advantage of PFS if ER is more than 50%. So the percentage of ER/PR matters. And again, there is an intriguing data of Allred score is that if ER Allred 7 or 8, there is no PFS difference. But if there is Allred PR 7 and Allred PR 8, there is a huge difference of PFS is there. And if PR more than 80%, and we would find a longest median PFS is there. So I was stressing on that Allred score, right? So we can put a final diagnosis of this case as a endocrine sensitive, HR positive, HER2 negative, BRCA negative, postmenopausal MBC with echo PS1 and no visceral crisis. So how would you proceed, Dr. Ankit?
Okay, so CDK4/6 inhibitor plus fulvestrant or an aromatase inhibitor, I think is the option, and is the I think I usually practice with that. I usually use either fulvestrant or aromatase inhibitor with CDK4/6 inhibitor.
Perfect. So whether this visceral metastasis of liver and lung metastasis doesn't prompt you to start the chemotherapy.
No,
right?
unless the patient is not in visceral crisis, I think. But still, even in, I think we can discuss that later probably. But presence of metastasis, organ metastasis without organ dysfunction, I think this patient is a very good candidate for CDK4/6 inhibitor.
Okay. So Dr. Ankit has rightly pointed out that we have all 6 options are there, but practically CDK4/6 plus AI or Fulvi is the way to go. So Dr. Jay, how would you choose it? Any specific demarcation of AI or Fulvi, or randomly you can choose?
Generally, I prefer to use the the AI with the CDK4/6 as a first line therapy.
Right. Any specific reason for that?
One thing is because the AIs are available orally, and fulvestrant we need to give injectable and every 15 days for first month and then every monthly. So the convenience is the I think the first issue. And both are, I think, equivocal in terms of efficacy. So AI is more convenient for along with CDK4/6. Second thing is the cost. So letrozole is very much very much cheaper as compared to fulvestrant.
Okay, fair enough. Fair enough. Okay,
Dr. Gaur.
Yes.
Just one point here. Am I audible? Hello.
Yes. Please, Dr. Bose. Please
Is
go
that
ahead.
this patient has already been on hormonal therapy? Would you want to check the ESR1 mutation status before deciding between AI and fulvestrant?
So we'll come to that point. We'll come to that point. All right. Okay. So Dr. Ekta, do you want to differ with Dr. Jai, or you resonate his words, same words?
No, same words. AI with CDK4/6 inhibitor followed by fulvestrant to be used in second line.
Right. Dr. Virappa?
Yes.
Same. Virappa, your voice is slow, very slow.
For ribociclib, I will plus fulvestrant or aromatase.
All right. Okay. And Dr. Jignesh, AI or fulvestrant with CDK? What would you choose?
Sir, AI plus CDK plus
Okay.
4/6 inhibitor.
Okay. So my point in this situation would be like that. You can choose both, and the both data is available. The data with AI is available. The data with fulvestrant is available. And as Dr. Jai has rightly pointed out about the convenience of fulvestrant with AI, that is fair enough. My point is that I would use AI upfront rather than fulvestrant, because Dr. Bose is eager to narrate the story of ESR1, and that the fulvestrant is the drug that can use with such kind of ESR1 mutation. So I want to reserve that fulvestrant into second line. So it would be a better option.
In case of PIK3CA mutation, we have data with the fulvestrant, so that we can reserve that line in the molecule in the second line with fulvestrant.
Absolutely. Perfect. Yes. Okay. So and the patient is not affording, or they don't want to spend the money like a penny pincher, so they can use the Palbo plus AI. As the generic version of the Palbo is available right now, so it is not very much costly. So we can use Palbo plus AI or chemotherapy, and patient is affording, we can use either the Bribo plus AI, Abema plus AI, and so on. So we'll do the hair splitting of one by one CDK now. So what about the palbociclib data? So are you satisfied with the updated data of Palbo? Then Dr. Rusab has already elaborated all the points. Said in Palomar 2 recent data not suggestive of OS advantage, but again some missing data is there. Also, the real world data with palbociclib is with suggestive that the OS data is there. And what about the dose and schedule of palbociclib, and how do you find Palbo in terms of side effect? Dr. Jai, yes.
So practically, I don't think the palbociclib and ribo and abemaciclib, they are different in terms of efficacy. But of course, based on that Paloma data, I think OS benefit is not seen with palbociclib, and it is seen only in the ribociclib. So But practically, I don't think they are different in terms of efficacy.
Okay.
The dosage, I think 125 milligram once a day for 21 days and 7 days off. That is a standard schedule of palbociclib. And most common side effects being the leukopenia with neutropenia. Majority of them, they are grade 2 and doesn't require dose modification. And I haven't seen any patient with febrile neutropenia. So they are safer in terms of side effects.
Fair enough. Fair enough. Okay. So, Dr. Jignesh, specific question. Are you satisfied with the updated data of Palbo, that is Palomar 2 and 3?
For overall survival, sir, there is not satisfied with OS. PFS, yes, definitely PFS benefit was there, but not for OS because it is not statistically significant.
Okay. So, Dr. Jignesh has rightly pointed out the point that is updated in October 22, the final OS, no benefit. And Dr. Rusov is showing that 90 month, that is 7.5 year month OS, no no OS advantage, and hazard is crossing the line of unity. But the silver line is that if DFI is more than 12 months, then OS is there. And again, the survival data, some of the patient, the survival data were missing for many patients. And in Paloma 3, that again last update in August 22, again the biology, favorable biology of the disease that favors the that drives the good OS compared to disease, compared to drug. So there is a favorable OS in endocrine sensitive disease, and in protocol specified OS we can have a OS advantage, and it is only clinically meaningful improvement in OS, but not much statistically significant. All right, so we move to the ribociclib data. So my question to Dr. Ankit, so are you delighted regarding the Mona Lisa 2 and 3 updated data?
Okay, so honestly, ribociclib has been publicized because it has been one of the CDK4/6 that has shown OS benefit. But I think I agree with the other panelists and Dr. Jay that I don't think personally all the three CDK4/6 are very different in efficacy. It just depends on your personal experience. My personal experience has been very, very good with palbociclib, so I tend to routinely use palbociclib. Ribo, yes, I have used with some side effects related to the ribociclib. So I generally tend to use palbo more often in my patients. But regarding the OS data, yes, it's a very good data, promising data, but that does not lead me to specifically use ribociclib in most of my patients. That is what I generally practice.
Okay, fair enough. So, Dr. Ekta, does Right Choice trial give you the warrant to use Ribo in visceral crisis patient?
So I think ribociclib is based on this Right Choice trial. It is an alternative option to chemotherapy. So we can discuss with the patients, and ribociclib to be specifically used in this hypothetical case 1 type of patients, which is nearly about to go in a crisis. In that subset of the patient, ribociclib is a good choice.
So how do you find ribociclib, Dr. Ekta? Have you used this drug?
Yes, I have used, and as a dose is in a 200 milligram to be taken 3 tablets. So whenever the dose reduction is required, it becomes very easy, particularly in that sense. Otherwise, for toxicity, I'm not worried about bone marrow suppression ever.
Okay, so regarding the ribociclib data, we have the Mona Lisa 2 and 3 and 7, and all three trials have shown the PFS advantage of using ribociclib in first line as well as the second line with AI or with fulvestrant. And if you can see the Mona Lisa 2, there is 1 year absolute OS in intention to treat patient analysis, and the data that all oncologists want to see. And in Mona Lisa 3 study, Ribo plus fulvestrant in first as well as second line, 16-month absolute OS according to per protocol analysis. And in Mona Lisa 7, Ribo plus AI in first line setting in perimenopausal woman and trend towards the better OS. And regarding the dose reduction, there is a study of Emily study, and they have studied 400 milligram ribociclib instead of 600 milligram, and they have shown that there is less neutropenia and less QT interval, and with some sort of same PFS. So, and with the hair splitting of the right choice trial, if we do, then the strength of right choice trial is that it is the first and only trial address this issue of visceral crisis, and approximately 50% patients is a visceral crisis. And we have got a 1 year of DS with H1 of 0.5, and overall response rate, time to treatment failure was almost similar compared to chemotherapy arm. And in fact, there is a better side effect profile of Ribo arm compared to chemo. And some caveat is that small number, as there is a phase 2 data, because we could not get the specific visceral crisis patient in an ample number like that is in a non-visceral crisis patient. And the benefit, the quantum of benefit is less in ER less than 50%, and if the disease biology, again the disease-free interval is less than 2 years. So drug that is abemaciclib. So I would like to ask Dr. Joy, so what is your insight for result of Monarch 2 and Monarch 3 data? Are you excited?
So, as I previously told that I don't think there is practically any difference between all the 3 cyclibs. So I'm not that really excited, but I need to mention one thing is that the abemaciclib is somewhat good in some subset of patient like liver metastasis, and also it has some good CNS penetration as compared to Palbo and Ribo. So in that sense, I think abemaciclib would be good. The second advantage of Abema is it has to be continued daily, so no need to remember the 7-day off period. So I think that is good, and there is some the hematological toxicity would be somewhat lesser as compared to the other 2 CDK4/6. So in that sense, the abemaciclib has some advantage over that. Otherwise, I don't think it is.
The hematological toxicity is lesser, but at the
the GI toxicity
area
would be higher in
is
thromboembolism. Yeah, that
Alright,
is
alright.
a different thing. Yes.
So, Dr. Jignesh, I want to ask, does your decision change in view of real world data of thromboembolic events in Abema?
Dr. Jignesh has left due to some emergency.
Okay, all right. So, can I pass this question to Dr. Irappa? Dr. Irappa, does your decision change in view of real world data of thromboembolic events? As recently published data shown that abemaciclib has approximately 7% rate of thromboembolic events compared to that they have showed in clinical trial there is approximately 3 to 4%.
No, it's more than 2/3, I think, in the real world
Yes,
data
sir,
that they have shown.
definitely there is data showing 5 to 7% thromboembolic events. At least in the metabolic syndrome patients, we have to reconsider it, whether to use it or not, whether to consider other things like ribociclib or palbociclib. 5 to 7% is a very good number of thromboembolic events. So at least we can avoid in any patient with CAD, coronary artery disease, and any ischemic heart disease plus cerebral events.
Okay, and this is the data are from a real world, and they have found that if patient has thromboembolic event with the abemaciclib, they have shorter OS, that is only 9 months compared to 25 months that where they didn't develop the VTE, and it is almost double compared to shown in the clinical trial. So are you going to use thromboprophylaxis according to this data in abemaciclib patients group?
No, sir. At this stage, because we don't have any data.
Okay, all right. So we can conclude with HR positive, HER2 negative, MBC in first line, second. All our panelists agreed that Ribo or Abema with AI or fulvestrant we can use as a first choice, or palbociclib we can use. But in my choice, the palbo plus AI if patient is not affording, and the ribociclib for dose reduction we can use, and that doesn't derail the overall PFS of the patient. And Ribo plus AI can be used in visceral crisis, some form of visceral crisis according to the right choice data. So with this, let's move to the case 2. So this is 62 female, hypertensive, controlled diabetic, no family history, and in March 21, she has been diagnosed with de novo MBC, multiple asymptomatic bone only metastasis, ERPR positive and HER2 negative, and she was put on upfront palbociclib plus letrozole plus ZA, and within 4 months of CDK plus AI, she developed liver and lung visceral metastasis, not in a visceral crisis, with echo PS1. So I would like to ask Dr. Ekta, how would you proceed this case?
So it's I think so it fits in endocrine resistant criteria.
Right. Right.
And at this stage, we can do liquid biopsy for PIK3CA and ESR1.
Any role of repeat biopsy?
The duration was
4 months, only 4 months.
I think PIK3CA and ESR1 can be done on liquid biopsy, but if suppose if we talk of PIK3CA mutation and if it comes negative in liquid biopsy, then tissue then also the archival tissue is can be used. So I think repeat biopsy is not required in this case.
So my question was that within 4 months of shorter period duration, I think the disease biology won't change regarding the ERP and HER2 status. So we can do repeat biopsy, but the NGS panel, that is I will show in the next slide. And there is a specific subset that is HER2 low disease, and this word is buzzing around the medical oncology field, and the definition is that HER2 plus 1 or HER2 plus 2 with that is FISH negative. These patients are maybe HER2 low disease. And why I'm pointing this HER2 low in this HR positive patients group is that the 65% of HR positive are HER2 low disease, or 37% of TNBC are HER2 low, and HER2 low biology is driven by HR status. And there are separate two groups. There's two school of thoughts are there. Some consider HER2 low disease a separate entity, and they have the data of approximately n number of 9,000 patients. And there are different school of thought, and they have the data number of approximately 70,000. So my question is to Dr. Joy, how do you see HER2 low disease in 2023? Is it a separate entity or not a separate entity? Because we have a dramatic data of TDXD in HER2 low disease.
Yes, so after the newer molecule, the TDXD, the HER2 low is coming into limelight. So I think HER2 low disease is likely to be treated as a separate entity in future.
Okay, and adding more salt to this matter is that some discordance. So this data is published in JAMA April 22, and they have explore what amount of discrepancy with HER2 score, like HER0 and 1 and HER2 2 or 3, and they have selected 18 famous pathologists to check the HER2 slides, and they have pointed out a 4-point scale, and they have found out that there is a 75% discordance in HER2 0 or 1 and 40% discordance among the pathologists in HER2 +2 or +3. So my question to Dr. Sanjay Gandhi, why is it so? And still HER2 disease finding, still it is subjective finding in 2023, and how would we amend it?
Yes, if we see good centers, the concordance of HER2 new, especially in equivocal and positive cases, was around 80%. But if HER2 new is negative, the concordance is 91%. The most common cause is a little bit subjective interpretation in 2+ and 3+. In 3+, intense complete membrane staining in more than 10% is considered positive, while moderate intensity will be considered as 2+ and equivocal. So that is one of the cause. So it may depend on intra-observer interpretation, as well as also depends on which type of the clone you are using, also depends on the pre-analytic, whether biopsy was fixed immediately or not, and whether the lab is using standard operating procedure. To minimize this concordance, ideally the tissue should be fixed immediately before 30 minutes to avoid cold ischemic time. Tissue should be fixed in 10% buffered or neutral buffered formalin. It should be fixed at least for 6 hours and not more than 48 hours. Lab should follow their standard operating procedure, and lab should show 95% of concordance with another validated lab. If you match all these protocols, the concordance has been seen up to 93 to 95%. So that will help the patient to classify the HER2 low or HER2 positive cases.
Okay. All right. So my next question to Dr. Bose. So is in this case, so it is a it took the HR positive, HER2 negative MBC, and it is a endocrine resistant case, and patient has progressed within 4 months of CDK4 plus AI. So you have previously rightly pointed out the ESR1 mutation. So is this a specific gene mutation to be tested, or is a broad NGS panel is a way to go?
Yeah, I'll answer the question in 2 parts, Dr. Modi. One is that there are certain markers which may be evaluated even outside of NGS, like androgen receptor, especially in this kind of patients who have shown an early non-response. AR is also one of the easier options which can be tested and which does not require NGS. Coming to NGS now, as you know, we see that individual PIK3CA mutation is possible to be tested, but ideally now with so many drug options coming up, especially if we talk of the mTOR, AKT-mTOR pathway, it just makes sense to go for a broad NGS panel now that costs are also coming down, because one, it will give you an immediate treatment option, and second is it will give you other options which you can move later on downstream. For example, in this case, if you find that there is a something downstream of the AKT pathway, like a MYC amplification, which is not that common in breast but more in lung, then you know that nothing of this is going to work until and unless you go for something like a MEK inhibitor, binimetinib, etc., which I think is not available in India. So that option also of what will not work is something which will come to you if you do a broad panel testing. So I may be biased a little bit from the work that we do, but yes, I think the world is moving towards broad panel testing. That is your question number 1. Do you want me to talk about this second question, which is also
absolutely. You are right, and world is moving towards a broad NGS panel. Definitely. And regarding the second question, usually at Gujarat, what I understood is that usually we use NGS by Thermo Fisher method, and I think you are using Illumina method for NGS, right? So I just want your insight for that. Okay, what is the difference between Thermo Fisher and Illumina?
Okay, there are many differences, but in the interest of that, this is mainly a clinical gathering, I will say some basic differences. So Illumina's technology is amplicon plus hybridization based, whereas Thermo's technology is only amplicon based. What happens is that this leads to higher sensitivity when you have amplicon plus hybridization. That is the Illumina technique. Of course, if you see worldwide, somatic panel testing, somatic genes, it is mostly Illumina based. Okay. The other point is that Illumina is a paired end testing. So if you have a gene from 3' to 5' end, I'm going to basic genetic pathology. So Illumina sequencing will read it from both ends, and hence erroneous reads, there is a higher power to eliminate erroneous reads. Whereas the Thermo Fisher is a single-sided read. So it has more probability of errors both on the false positive and false negative side. Overall, if it is a limited small panel, which you want to do at lesser cost, it is a lab's predisposition. The lab will benefit more if they use Thermo. And I think Gujarat being highly price sensitive, that is the reason why some of the labs have chosen to do that. But if you really, as we said, the world is moving towards broad. If you are doing comprehensive genomics, 500 to 1,000 genes, you don't want to lose out any prognostic predicate or theranostic marker, then the way to go is Illumina.
Okay, and there is recently a new publication regarding the liquid biopsy breast cancer methylation. So what is that?
Yeah, so basically methylation, there are certain regions in several genes which attract a methyl subgroup CH3, which comes and binds to that. Now methylation is in specific genomic regions is a characteristic of malignancy. It indicates two things. One, if you are looking at specific genes which are getting methylated, you can subtype or classify which cancer it is. But more importantly, from an MRD standpoint or minimal residual disease standpoint, you can score this methylation as compared to a baseline methylation, which happens in normal genes. And you can look at it something like a quantitative ctDNA, circulating tumor DNA concentration, or a CTC concentration also as a third marker for disease quantification. So I think one of the most important use of methylation, which is going to come within the next 1 to 2 years time, is for MRD evaluation. So the assay can be performed basically by PCR as well, or by digital droplet PCR, but ideal way is NGS, because you can do a very broad region of genes or very broad panel of genes and test it for methylation. And this is not going to be a very expensive test as well. So I think, the NGS based methylation is an assay which can show you prediction for response to treatment or non-response to treatment, and it can also be used for disease survival. So this is a very useful paper which you are just showing, a recent one.
Okay, so I think all panelists would agree regarding that NGS is a way to go in at least in a second line setting of HR positive, HER2 negative, because there are ample and myriad of the mutation that we have found recently regarding ESR1, PIK3CA, somatic and germline BRCA, NTRK. Again, there is a HER2 mutant, non-amplified varieties there. If you want to use the IO, then MSI and TMB would help. And AKT activation mutation has already discussed by Dr. Palak. And again, on the way is PTEN inactivation mutation. So Dr. Jay, are you excited with the data of ESR1, PIK3CA, HER2 mutant non-amplified variety, or like a very geek to us, isn't it?
So yes, definitely in endocrine resistant cases, I think in this era of I think the molecular biology and the precision oncology particularly, I think the ESR1, PIK3CA, HER2, and all this broad molecular mutations that there is the future in that mutations. So yes, I'm really excited in future for treating these endocrine resistant cases.
So there is an interesting data available regarding the ESR1 mutation is that if the prevalence of ESR1 mutation is in ET9 MBC is approximately 1%, and the prevalence in adjuvant AI is approximately 4%. But once you use AI as a first line therapy of de novo MBC, the percentage is 40%. So it is like a PIK3CA. And once patient found ESR1 mutation, it is partially sensitive to tamoxifen, and letrozole is completely out of the box if patient has ESR1 mutation. Some sensitivity to the high dose of fulvestrant, some data of abemaciclib is there. And as we all know that PIK3CA is a at present highlighted point, because 40% cases of MBC, if we specifically categorize the HR positive, HER2 negative patient subset, and we can definitely use alpelisib with fulvestrant. SOLAR-1 has the data, and this trial met the primary endpoint of PFS and of almost double PFS. And the last update in November 20 is that there is no statistically significant OS advantage is there. And there is a new entity is that the HER2 mutation non-amplified version. So usually we do HER2 by ISC and forget about the HER2, but there's a new variety and it is only picked up by NGS, that is somatic mutation of HER2, and we have the data of drug like neratinib, and we can use that. So at present it is not available in India, but the future is only such kind of drugs. And there is some
So
data.
I need to add one thing also. There is a new data available for elacestrant for that ESR mutation
Yes.
based on Emerald trial. So it's a oral that down regulator.
Yes. Definitely. And also there is some partial role of trastuzumab we can use in HER2 mutant non-amplified MBC. So once we thought that it is a HER2 HR positive, HER2 negative, and we cannot think about using trastuzumab in those subset of patients. And we keep on discussing ALK positive in lung cancer. There is 3 to 4%, and here the HER2 mutant non-amplified MBC comprises 2 to 4%. So it looks similar, and I think these are the future of medical oncology.
Dr. Modi, one more point if I can add, because you spoke about HRD, and here again there is a combination of everolimus mentioned here. So another advantage of broad comprehensive genome testing is the evaluation of homologous recombinant deficiency, and this is going to, what we see the trend, it is going to come in a pan cancer application, because those small gene mutation based HRD testing is being replaced by proper HRD testing, which has loss of heterozygosity, telomeric allelic instability, and large state transitions all included. And we see a very large percentage of pre-treated metastatic cancer patients, not just breast, but even lung and GI, where there is HRD deficiency, and maybe not as a single agent PARP inhibitor, but combination with other drugs. These patients have a hope, especially if you don't have PIK3CA mutation, if you find that this patient has not responded to fulvestrant as well, and rather than going down just to chemo options, you have that PARP inhibitor combination based on HRD deficiency.
All right. So we are running short of time. Dr. Pankit, I would hear your quick insight of, do we have the data of switch to another CDK4/6? So this patient has palbociclib and progressed within 4 months. So would you use Ribo or Abema in this patient? Do you have the data?
There is a small data, but it's still, I think, does not have. It has still, I think, it needs some time. We need to give some time for further or a large amount of data to suggest whether we can switch or not. But yes, there is a good promising phase 2 trial of ribociclib. I think we can, but still a long way to go probably.
Definitely. So some benefit of adding Ribo plus Fulvi if patient has progressed to Palbo, and again the benefit is approximately 2.5 to merely 3 months. According to the maintained trial, data is very slender, and I think in future we have the data of switching the CDK. And I would like to ask Dr. Ekta, do we have the data of continuing CDK4 even after progression? So can we use continuation of Palbo in this patient? Do we have the data? Ekta is there? Dr. Ekta? I think Dr. Ekta is there. Dr. Jai?
So I don't think that there is a trial for palbociclib, I think phase trial, but it didn't show the benefit to continue the palbociclib as a second line option. So I don't think continuation of the same CDK4/6 will be beneficial. I think the switching technique would be rather somewhat beneficial in that, like changing palbo to ribo.
Fair enough. So in conclusion, we can say that HR positive, HER2 negative, MBC in second line setting, overall picture remains poignant, and a broad panel NGS can be contemplated in both prognostic as well as predictive way. And no women data in terms of changing CDKI. We have the data in maintained trial from Palbo to Ribo, but data is very slender. Or continuing CDK, the PACE trial is a failed trial after progression of CDK. And if PIK3CA or BRCA gene mutation is there, that like target drugs are available, so we can use it. Otherwise, fulvestrant or chemotherapy is the way forward. And data has emerged for HER2 low disease, but still way to go. So if I summarize all this thing and what is revamped landscape in 2023, then if patient has endocrine sensitive, then we have the data of CDK plus AI, and in a first line setting, and if it's progress, then we have to do a PIK3CA mutation, and if it is positive, we have to offer alpelisib plus fulvestrant, and if it is a negative, that is PIK3CA wild type, then fulvestrant is the option. And in third line and fourth line, both are the same group. We can use exemestane plus everolimus or combined chemotherapy. And if patient has upfront endocrine resistant, then CDK plus fulvestrant is the choice of the drug. And then again, second and third line will be everolimus, exemestane, and chemotherapy. And if at all patient is affording and can do NGS, then according to the mutation report, we can explore the data. So thank you.
Thank you, Dr. Gaurang Modi, and all the eminent faculties and panelists for making this wonderful panel discussion and giving your insights on hormone positive metastatic breast cancer. With this, we come to end of our day 1 sessions. I would like to extend my heartfelt thanks to all the eminent faculties, delegates, my colleagues and dear friends who had joined to make this academic feast a wonderful discussion on day 1. I would like to also thank my scientific partners those who and also Healthy Blossom team and my team Oncovin for making this event possible. We are still going to have interesting discussions about triple negative breast cancer, HER2 positive breast cancer, and having some exciting panel discussions on day 2. So we'll, everyone join right back at tomorrow 6 p.m. for further discussions. Thank you everyone and good night.
Thank you, Hitesh bhai. Thank you.